I welcome all of you for our prestigious mid-year conference, pre-conference workshop. It's my pleasure to call our President Ma'am, Dr. Vijayalakshmi Sheshadri Madam, to give welcome address. Over to Ma'am.
Good afternoon, everyone. My heartfelt welcome to all the people who have logged in today, to respected professors, the seniors, my friends, my colleagues, all the entire EC committee members, the invited faculty from everywhere, the international faculty, Dr. Asma Khalil from London and Dr. Tony Tan from Singapore, the orator for tomorrow, Sir Sabaratnam Arul Kumaran sir, Dr. Mandakini Meg, the ICOG chairperson, who will be giving the keynote address, all the faculty for today and tomorrow, the coordinators, my friends, colleagues, all of you are welcome to this academic bonanza that we will be watching today and tomorrow. We had posted presentations earlier in the day, and now we will be moving ahead with OGSSI prayer by our secretary, Dr. D. Geeta, and then we will soon follow it up with the workshop. Welcome you all for this afternoon session of the workshop on the multiple pregnancy, multiple challenges, which forms a part of the pre-conference workshop of our mid-year conference of the Obstetric Gynec Society of Southern India, themed at Together We Win, and that was designed to include the discussions of the obstetric gynec cases with different specialities. So over to Dr. Geeta for the OGSSI prayer.
Every positive thought is a silent prayer that will change our life. Prayer is a positive force. Always we begin our program with our OGSSI prayer. Thank you, God. In humility we gather. In gratitude we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and a mom reborn, the courage to deal with it all when things are not perfect, and to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love.
Thank you, Geeta. Now, this is the workshop which was from the time of conception till today has been coordinated and organized and in fact all put together into today's shape by my own executive committee member, Dr. Uma Ram, and many thanks to her for bringing it all together. So over to Dr. Meenakshi, who will be the coordinating the first session to go on with the proceedings of the workshop. Thank you, Meenakshi.
Thank you, ma'am. A very warm welcome to one and all, and the faculty and the delegates who are here for today's interactive workshop. We'll start the first session. We have 3 chairpersons for this lovely session. Can we have the slides of the chairpersons, please? Yeah, I welcome Dr. Jayashree Gajraj, ma'am, Senior Consultant at Apollo Specialty Hospital and MGM Specialty Hospitals, Chennai, Director of Mangai Women's Health Exclusive, Past President OGSSI, and immediate past chairperson of the AICC OGSSI. I would like to welcome the next chairperson for the session, Dr. Painiyappan sir, Professor, Unit Head of Obstetrics and Gynecology from SRMC Chennai, is the immediate past president of OGSSI. He had the traveling fellowship, A.L. Mudaliar Traveling Fellowship in 1988. He was a Yuva OGSSI orator. He was a Young Gynecologist Awardee of AOFOG 2007, past chairperson of Safe Motherhood Committee FOGSI, and the new grandparent in vogue. I'd like to invite our next chairperson, Dr. Rajapriya Ayyappan. She's the secretary of Indian Fertility Society, Tamil Nadu chapter, EC member of OGSSI, secretary of the Perambur IMA Women's Wing. She got the Best Doctor Award in 2018. She's the managing director of Srinivas Priya Hospital and Home Fertility Center, Chennai. Over to the three chairpersons to introduce our speakers for today's session. And I call Dr. Payaniappan sir to introduce the first two speakers to start the session. Thank you.
Good afternoon, ladies and gentlemen. President Dr. Vijayalakshmi Seshadri, Dr. Uma, Dr. Meenakshi, it's been wonderful having put me into this workshop. And let me have the privilege of introducing the first session speakers. And we are having something different called Chorionicity, the cornerstone of management. It's a dialogue on twin pregnancy between two people here. One is Dr. Sudarshan Suresh, who's fellow of fetal medicine in Mediscan systems, and his clinical focus, first trimester ultrasound screening, prenatal diagnostic therapeutic invasive procedures, are well known to the entire state, probably the whole country, and he's a trainer at the fetal medicine program in Mediscan. And Dr. Suresh has been trained through the genes, should I say that. And the next obstetrician gynecologist from our side is Dr. Shobana Mahadevan, who's a consultant at the Sitapati Clinic and Hospital, Apollo Hospital, Chennai, member ATN RCOG and Part 3 MRCOG examiner. I only wish I could take the MRCOG exam again, having known Dr. Shobana so very well, if that works that way. So with that, a few small introductions, which we have put it on the slides. Both of them are extremely academic persons, and we move on to them to go on to the dialogue on chorionicity, the cornerstone of management in twins. Over to you, Dr. Sudarshan and Dr. Shobana.
Thank you for the kind words of introduction, sir. Hope you can hear me.
Yeah, Sudarshan, very clear.
Yeah, let me just share my screen now. You can see my screen, sir? Sir, I can't hear you. You're muted, sir.
Very clear, Sudarshan. Go on.
Okay. Very good afternoon for the having put up this interesting session today on multiple pregnancy. And myself and Dr. Shobana would be starting this session with the basics of twin pregnancy, and which is chorionicity. So the scope of today's discussion in the next 20 minutes is going to be how important is chorionicity as a key to the diagnosis and the management of multiple pregnancy. And we would be doing this as a dialogue between the two of us, and we'll see how we can clarify certain simple issues there. Okay, let's start with the basics. Dr. Shobana, this is Mrs. Y, who comes to you with the below ultrasound report. And how happy are you with this? This report says there's a twin gestation with 2 viable fetuses. Seems good.
Good afternoon, everyone. Thanks, everybody, for the wonderful opportunity. And I am very grateful to be part of this very important, relevant workshop today. Sudarshan, this is often the kind of report we get. So am I happy with this? No. Because as we will see at the end of this 20-minute interaction and at the end of the workshop, chorionicity is going to be crucial in managing twins. And the key here is we are looking at this report at 9 weeks. So is it enough just to say twins at 9 weeks? No, I would definitely like to know chorionicity also at this point in time. So
is it better?
Yeah, this is much better. And we will see why this is better as we go on.
Yeah.
So here we have the confirmation of twins as well as the chorionicity.
Yeah. So let's start with the basics. So what is zygosity and what is chorionicity? Are they both the same, or is there any subtle difference between the two?
There is subtle difference between the two. Zygosity is an embryological term, whereas chorionicity is embryological as we seen on ultrasound. So zygosity, as the name denotes, it arises from the word zygote. So one zygote, one embryo. So if there is dizygous pregnancy, two embryos, and therefore they give rise to dichorionic diamniotic pregnancy. That is the commonest form of twins. If there is a monozygous conception, that is a single zygote, single embryo, then that can undergo cleavage to give rise to twins. And now, depending upon what stage of pregnancy the cleavage happens. If the cleavage happens very early on, before day 4, before the formation of chorion itself, then it gives rise to two chorion, so dichorionic diamniotic. If the cleavage happens between day 4 and 8, which is the commonest time at which the cleavage happens, then the chorion has already formed and therefore it is monochorionic and diamniotic. If the cleavage happens a little later, you could have monochorionic, monoamniotic, and very difficult situation if the cleavage happens very late on. So what I'm saying is, if you have a monozygous pregnancy, conception, then that can give rise to dichorionic as well as monochorionic pregnancy. Dizygous will give rise to always a dichorionic diamniotic, whereas a monozygous majority will be monochorionic, but some of them can also give rise to dichorionic pregnancy. So there is a subtle difference between zygosity and chorionicity, but for all practical purposes in twins management, barring a few, we would take chorionicity as the main factor that will determine our management.
Yeah, because we can't identify the zygosity on ultrasound, right?
Yes.
So we only are focused on what kind of chorionicity it is. And we've seen all various combinations are possible on both sides. And since we do not know what kind of zygosity it started out with, it's pretty important for us to clarify the second part by ultrasound. And both of these same, can you look at these three images? The first one seems very, very simple and straightforward. Two separate placenta, and this is a dichorionic twin, right?
Yes, the first one, the two placentae are far apart, and therefore it is very simple to call it, diagnose the chorionicity. It's dichorionic. In the second and third images,
There seems to be
it looks like a single placenta. So therefore, can we assume this as monochorionic?
Yeah.
Is it just a fused placenta of two placentae, or is it a single chorion, monochorionic pregnancy? So that's the confusion that can arise out of the second and the third image.
And
So,
can we clarify this one by ultrasound? I guess so.
Yes, yes, definitely, because the difference between the second and the third is the vascular anastomosis, apart from other things. So on ultrasound, there are certain signs which will help us to differentiate between dichorionic and monochorionic placentae, even though the placentae of a dichorionic pregnancy are close together.
Yeah. So we'll look at that. So what is amnionicity? Because you were talking not only about chorionicity all along, you were saying there can be monochorionic diamniotic or a monochorionic monoamniotic. How different is this?
So if you see, there are three images. In the first one, the red plate is considering that as a chorion. You have two dichorionic and diamniotic. And in the second one, there is a monochorionic but two amniotic sacs, monochorionic diamniotic. And the third one is a monochorionic and monoamniotic. So Sudarshan, can I ask you, how early can we detect this difference on ultrasound? Because this seems to be a confusing thing and it may be very important. So when we get a 4 to 5 week scan with this kind of image, will you be able to tell us categorically about the chorionicity?
Yeah. So when we do the early pregnancy scan, two key things we need to understand is, one, it is always done by the transvaginal method and not by the transabdominal method, because the resolution and your ability to discern the gestational sacs is much, much better. And second, this is rule number one, that is, the number of gestational sacs that you see in the early pregnancy is by rule of thumb equal to the number of the chorions. And I'm here clearly saying that it doesn't tell about the number of fetuses, but it only tells about the number of chorions. So you see two gestational sacs on the first image. So this is a dichorionic twin pregnancy. And here on the second image, this is very commonly, we do see this in early pregnancy. We see a single gestational sac, and sometimes we are left with surprise that when we see the pregnancy back at around 9 weeks, we see two babies sitting inside. So in the early pregnancy scan, prior to the appearance of the yolk sac and prior to the appearance of the fetal pole, it's extremely difficult to rule out the possibility of multiple gestation, even when you see a single gestational sac, which means when we put it across as an ultrasound report, when you see this kind of a picture in the early pregnancy scan, I would report it as there is a single intrauterine gestational sac. We would need to review back at the 8th week to assess the viability and the number of the fetuses. Yeah.
Okay. So this pregnancy has gone on to 7 weeks. Now in the first image, I see two poles, fetal poles. And in the second image, I see two yolk sacs also. So will you be able to determine the amnionicity or chorionicity categorically at 7 weeks?
Yeah. So here from the previous picture, now when we have moved on, we have seen that the fetal poles have appeared. So the number of fetal poles is equal to the number of gestations that you see. So this is definitely a twin gestation. And you're seeing one gestational sac. So gestational sac equal to chorion. So we have simplified this that this is a monochorionic twin gestation. Okay. When we see two amniotic, two yolk sacs, the number of yolk sacs generally refers to the number of the amniotic sacs, but that is not the case all the time. And hence, at 7 weeks, when we are unable to discern the amniotic sac clearly, I would put it across as a report like this. That is, this is a monochorionic twin pregnancy. I have not commented on the amnionicity, and I would report it that we need to see the pregnancy back at the 12th week for a first trimester ultrasound and establish the amnionicity of this pregnancy. And this pregnancy came back at the 12th week, and you can see this image now. It's much clearer. Here you couldn't see any amniotic sac in the first picture, and in the second picture you're able to see the amniotic membrane clearly, and hence this is a monochorionic diamniotic twin. So early gestation, 7 weeks, only report on the chorionicity and the viability, not on the amnionicity. And when you get back, then you can report on the same at the 12th week scan.
Okay, so to recapture this, the previous slide, Sudarshan. So
Yeah.
to recapture this, so when you have a single gestational sac, the previous one, Sudarshan.
Yeah.
So the first image is single gestational sac, so it is monochorionic twin pregnancy because we have two fetal poles. In the second one, we find two yolk sacs, so there is a possibility that it could be diamniotic, but we need to confirm this later. We cannot comment about this amnionicity at 7 weeks. Okay, yeah. Am I right?
Yeah, and we have reached now 9 weeks. Are things clearer than at the 7th week?
Next slide, yeah. Yeah, now even I can make out that it's a diamniotic pregnancy. We have already ascertained that it is a monochorionic pregnancy. So we have two separate amniotic sacs. So the earlier suspicion of, earlier assumption that it would have been diamniotic based on two yolk sacs has come true. So it can be reported with certainty. So this brings me back to the first report that you asked me at 9 weeks. We need this much information on the report when we get a report of a twin pregnancy at 9 weeks.
So you want both the chorionicity and the possible by the 9th week scan, as seen in the first case with Mrs. Y. Okay. So so this is Mrs. Z, who comes with this ultrasound report at 12 weeks. And this is the first trimester scan report. Now we have moved on from the 9th week to the 12th week. And this report again gives you that there's a twin intrauterine gestation at 12 weeks with viable fetuses, concordant CRL, and the report says we're finding it difficult to determine the chorionicity. So you review back at the 18th week to assess the same. This is the ultrasound report you have dealt with. And when you see such reports in your clinic? And if you see that, what do you do? Do you refer to determine the chorionicity now, or you simply recall at the 16th week because baby will be bigger? It's much easier to check, or we can see everything with the target scan. Why keep calling them back and forth again and again?
Okay, thankfully, Sudarshan, we don't see this kind of reports that often anymore, at least in our part of, in our city. But
Yeah.
nevertheless, we could see something like this, and it's important to immediately refer to a center where chorionicity can be determined accurately, because a lot can happen between now and 16 weeks, and we need to monitor the twin babies slightly differently depending upon the chorionicity, as we're going to discuss further. And therefore, my answer would be to refer immediately to determine chorionicity.
Yeah.
So,
yeah.
We all know this. The dichorionic pregnancies have two leaves of chorion and amniotic membrane separating them, whereas it is only two leaves of amnion separating a monochorionic pregnancy with the vascular anastomosis shown below. So, how do you ascertain this, or how do you diagnose this on ultrasound, Sudarshan?
Yeah. So before I go into the ultrasound part, what I would want to push across is this part of the slide, which says how specific and sensitive is ultrasound to ascertain the chorionicity at this point of time. It is close to 98 to 100%. So we cannot escape from that fact, and we've got to report that at this juncture. So this is the first slab of images. When you can see on the top panel, you see clearly two separate placentae, one anterior, one posterior. Makes life simple. It's a dichorionic, diamniotic twin. Membrane is seen. If you go to the second panel and the video clip here, you can see a common placenta that's fused anteriorly. And that is because both the chorionic sacs got attached close to each other. And you can see the classical twin peak sign, as we call it, where the portion of the placenta moves between the leaves of the membrane here, and that is seen as a thick sign here, which is the twin peak sign. So when you see the twin peak sign, or when you see two separate placenta, then it's a dichorionic diamniotic twin. And when you move on, herein we can again see a common placenta, as we saw in the initial slide with the picture there. And here, however, you don't see the classical thick membrane here or the twin peak sign. What you're seeing is something like a T sign. This is called as a T sign of a monochorionic diamniotic twin. Again, this can be ascertained by the 12th week. If trans-abdominal imaging is difficult to see this, especially in a high BMI mother, we've got to go and do a transvaginal scan to determine that. And the last part, this is a monochorionic, monoamniotic twin ascertained in different planes. There is no membrane seen between the sacs. Both the fetuses are pretty close to each other, as you can see in this video clip.
I would like to add to that, Sudarshan. It
Yeah.
may be a very small factor, but it's always important to ascertain this different signs where the amniotic membrane gets inserted into the placenta. That is the site to look out, and not at the opposite area where it, of the membrane. Because we have had certain cases being reported like that. So it's at the place where the amniotic membrane gets inserted into the placenta.
Okay. So why are you so concerned about this? You were asking me about the different signs. You wanted to know how to report and image all this on ultrasound. Why are you so concerned about this?
First of all, chorionicity is best diagnosed before 12 weeks, at 12 weeks. So later on in the second trimester and in the third trimester, our ability to diagnose this chorionicity definitely decreases. Sometimes it may not be possible. So why should we know the chorionicity? The diagnosis of twins, once it is made, as much as we would want to join in the jubilation with the patients, it's important that we educate them, counsel them, that the course of pregnancy is going to be slightly different compared to singletons. And we all know perinatal morbidity and mortality is increased several times in twin pregnancy. And a lot of this is in relationship to monochorionic pregnancy. And therefore, we need to tell them there are there are two different types of twin gestations, and the outcome is going to be slightly different in these two. Because if we, for example, if we take aneuploidy screening that we routinely offer at 12 weeks, it's going to be, the interpretation of the result itself is going to be different between monochorionic and dichorionic, as we will see as we go along. And the way we follow up in order to pick up some of the complications that can commonly happen to monochorionic pregnancies, it's going to be very different between the two. And when one twin has an anomaly or an aneuploidy, the way in which we manage these pregnancies are going to depend upon the chorionicity. And it goes without saying that when we deal with higher order multiples and we plan a selective feticide or multifetal reduction, it's important that we know the chorionicity. So knowing the chorionicity is absolutely vital in the management of twins.
Yeah. So we move to the cases.
Yeah.
So these are two different kind of twins which came per unit. One was the first one was a twin where one baby was normal, other one had an anencephaly, and this again a twin with an anomaly where this one had a large omphaloceal that you can see here. And do you think it's important to know what kind of chorionicity it is at this stage?
Yes. So this is a typical situation where the twins are discordant for an anomaly. The first one being anencephaly, the second one being omphaloceal. So the management would entirely depend upon the chorionicity. Can you explain how that is going to be, Sudarshan?
Yeah, case one was actually a dichorionic twin. You can see two separate placentae. And case two, even when we don't need to see our scan, we can just go back to the early pregnancy scan. This is an early pregnancy scan done elsewhere, and you can see clearly the monochorionic diamniotic twin. So in case one, DCDA twin with one anencephaly, option of selective feticide, very simple by means of intracardiac injection. But case two is a little more complex. It's a large omphaloceal. In a monochorionic twin, you can't do simple feticide procedures, especially even if it's a multi-system abnormality. You got to follow the pregnancy up back at the 16th week, do a complete evaluation of the anatomy, and take a decision on whether it's conservative care, whether it's an operable condition postnatally, or whether we need to do any updated procedures based on what we see. So what management we do next completely changes based on what kind of chorionicity it is, as seen in these two pictures.
So the key message is that chorionicity is a must to plan management. The management as such being selective feticide will have an impact on the other healthy baby in the case of monochorionic pregnancy because of the vascular anastomosis.
Yeah. We move on to the next case.
Yeah. So this is also not an uncommon situation that we find in our clinic. In the early pregnancy scan done at 8 to 9 weeks, it was reported as a singleton. And then when we follow up on 12, 13 week scan, we get a diagnosis of twin pregnancy. Why does this happen, Sudarshan? What could be the problem, and can this be prevented? Or sometimes it is not preventable at all, avoidable at all?
I discussed the exact same thing when we started with our ultrasound images on the early pregnancy scan at 5 weeks. So in a very early pregnancy scan, where you can, which is why we only comment on the chorion and not the viable number of fetuses. But this one is an image taken at 9 weeks. At 9 weeks, you can actually see a fetal pole. And what has happened is that at the 12th week, one baby has been shown to grow normally. The other one is seeming like a hydropic fetus, and it does not have a proper limb or any proper anatomical architecture. So this, in essence, is a monochorionic diamniotic twin, and this is what we call a trap sequence. So when we see an early pregnancy scan with one viable fetus, many often what is seen is that we see a single gestational sac with one viable fetus and another non-viable fetus is noted, and it is reported as twin with one non-viable gestation, and the pregnancy is asked to follow up at 16 to 18 weeks. And what happens is that whenever we see that additional suspicious non-viable pole, we need to always call them back little early to see the color flow Doppler to know whether it is actually a trap fetus. So the key message there is, if in early pregnancy, if you see one sac and at 12 weeks you see two sacs, it is always a monochorionic twin. It can be a monochorionic twin with a trap sequence or a normal MCDA twin. If in early pregnancy you see one non-viable pole, as I said, always check the vascularity of the non-viable pole and review back at the 12th week to rule out a trap sequence. So we'll move on to case 4 with that. This was a patient who was referred to our unit as twins for a follow-up at the 28th week. And this was the ultrasound picture. There was a growth discordance of around 30%. And baby B had a normal umbilical Doppler. Baby B had, A had an absent end diastolic flow. And we asked them to revisit back in 1 week. In 1 week, this was the picture. Baby B Dopplers were still normal. Weight was around 1.2 kilos. The other baby was around 670 grams. Discordancy was actually much higher. But the Dopplers now showed a consistent reversal of the end diastolic flow in the umbilical Doppler. So what would you consider next, Dr. Shobna? Would you, is the chorionicity essential in this case? Or would you simply deliver her because we are seeing a reversal of flow? Or would you want to do a conservative care? Or what else do you want to do next?
Sorry to interrupt, doctor. I just want to just remind.
Okay. So you haven't mentioned.
Yeah.
Okay, we don't know the chorionicity. The issue here is there is severe growth discordancy and there is a risk of imminent IUFT in the second one. In this, definitely the chorionicity determination will impact, because if we lose the baby in a monochorionic pregnancy, we are going to, that is going to directly impact the healthy baby as well. If it's a dichorionic pregnancy, I would allow the healthy baby to grow and then deliver at the appropriate time. Whereas in the monochorionic, if it's a monochorionic pregnancy, we have to deliver the healthy baby now, because anytime the growth restricted baby is going to die, and that will cause severe problems in the healthy baby as well.
This was actually a monochorionic twin. As you just said, because of the high risk for the co-twin, decision was taken to deliver, and the baby had a stormy course, but it did survive. But we need to keep them for a long-term assessment. So if the same twins, we are seeing a significant discordance. You just explained that if it was a dichorionic twin, you would prefer to wait, right?
Yes, I would prefer to wait, because if we cannot salvage the growth restricted baby, then rather than delivering both babies prematurely, I would rather wait for the healthy baby to grow and attain a good period of salvageability, depending upon the neonatal setup that I am with. So the decision to deliver only if I know if I can save the smaller baby, if I have a very good NICU, then I would consider deliver. So otherwise, I would manage expectantly.
Yeah.
If it was a monochorionic pregnancy, but not 30 weeks, it was very early, 23 weeks, then what options do we have, Sudarshan?
So if it's a monochorionic twin, which is far from the time of viability as is seen in the second scenario, then we would need to consider some fetal intervention procedure to ablate the blood vessels of the growth restricted baby, so that we can have the other baby moving on safely through to the rest of the pregnancy. So it's very essential to know what is the chorionicity, and depending on the gestational age, we've got to take a decision on what we need to do. So because we're running short of time, I'll just quickly complete this session. The last message that I want to pass on is that when we see a twin gestation with no early scans at mid-pregnancy, it's very difficult to ascertain the chorionicity. And whenever we see an unknown chorionicity, we simply follow them up as a monochorionic twin. It would simply entail additional follow-up, but may identify an adverse pregnancy event early and help to decide what to do. So to conclude, chorionicity we need to ascertain early at the first trimester, and if in doubt, we need to refer them early. Follow-up is clear as per protocol, which will be discussed in the following sessions. as I always tell the patients when they say it's a hassle to keep coming back again for a follow-up, you got carried twins only once. Thank you so much. Thank you, Dr. Shobna, and thank you, team.
Thank you. Thanks.
Thanks, Sudarshan and Dr. Shobna. That was fantastic dialogue. And chorionicity has always been a chronic confusion, and you guys have really made it very well. And crosstalk went on really good. And thank you very much. And we move on to the next speaker.
Thank you so much, sir. I would request Dr. Rajapriya to introduce our next speaker, Dr. Vivek Krishnan. Rajpriya, just unmute yourself. You're on mute.
Sorry, I would convey my special thanks to Dr. Vijayalakshmi for pulling me into this fantastic program on multiple pregnancy. And in continuity with the first topic, we have Dr. Vivek Krishnan. He's a specialist in fetal medicine. He's the head of the Division of Fetal Medicine and Perinatology at Amrita Center of Excellence in Fetal Care at Kochi. He's authored Obstetrics 12 Long Cases, and he's also actively taking part in this program by enlightening us on the topic aneuploidy screening in twins. For the next 20 minutes, the session is all yours, Dr. Vivek Krishnan. We're looking forward to hearing from you.
Thank you, madam, and thanks to Umara madam and Vijayalakshmi madam for this opportunity. This opportunity to be talking among stalwarts and legends like Sir Arul Kumaran and Asma Khalil and Dr. Tony. I've been asked to speak on, I could share my screen. Is my screen visible now?
Yes, sir, it's just started sharing.
Okay.
Yes, you can make it full screen, yeah.
Yeah, full screen. Yeah, so I've been asked to speak on aneuploidy screening in twins. The premise for this lecture would be the fact that when you look at a population of twins from a screening perspective, you are looking at a population that is at high risk for aneuploidy by default. Because a lot of these twin pregnancies would have been born out of artificial reproductive techniques where you would expect the maternal age to be substantially higher than in the other cohorts. And therefore, when the maternal age is higher, we know obviously that the aneuploidy risks are going to be higher. But the flip side to that is these parents or these prospective parents with twins or multiple pregnancies are known to be less inclined to invasive testing because we know that there is this conception that the risks associated with an invasive testing in twins is much higher than with singletons. We also know from recent literature review, I mean, it was quite interesting that I came across this paper, which said that there is a perceived sense of increased psychological optimism among parents of multiple pregnancies. They believe that God has blessed us abundantly with twins or triplets, nothing can go wrong from here on, and therefore they're more reluctant to accept invasive testing. Now we know that nothing can be further from the truth that these babies are not at risk. We know that they are at significantly higher risk than singleton pregnancies. And what we also know is that unlike singleton pregnancies, there are certain challenges that are very unique to twins as far as aneuploidy screening is concerned. First, of course, as you heard in the last talk, is the interplay between chorionicity and zygosity. Then there's this problem of labeling twins. You call a twin as A in the first scan. You do a screening test. The screening test comes as high risk for twin A. They come back at 16 weeks for a procedure, and you really don't know which is fetus A and fetus B. That can be a complete disaster. So knowing how to label twins is also very, very important. Then comes a choice, the problem of choice. You have a lot of tests that you do for singleton pregnancies. Can you extrapolate the same to twins and do the same detection rate and false positive rate apply here? That's another question. And of course, if you decide to do an invasive testing for diagnostic information, there again you have choices whether to do a single amnio, a double amnio, a single PGS, a double PGS.
Dr. Vivek?
You're unable to see your slides, Dr. Vivek. I think the screen share has stopped.
Not again?
Yeah, now we can.
Okay. Yeah, so these are the 4 challenges that we would discuss with the rest of this lecture, and we will take these up one by one. First, of course, as has got to do with anything related to twins, would be the interplay of chorionicity and zygosity. And you heard very clearly in the previous lecture that the risk of aneuploidy is directly related to zygosity and not anything else, which means If you have monozygotic twins, as the name implies, it comes from one single zygote. And therefore, even if you have two babies, these babies cannot have independent risk. Both of them will have exactly the same risk. And therefore, the risk is always assigned per pregnancy. Whereas if you have a dizygotic twin pregnancy, then each baby has got its own independent risk because they come from completely different zygotes with different genetic makeups. Therefore, you would have to give a risk for each fetus and not for the pregnancy. So this is a major difference that you need to understand. For monozygotic twins, the risk is always given for the pregnancy and not for the separate twins. But for a dizygotic twin, the risk is given for each fetus independently. Now, the obvious logical conclusion that you would draw from this is that if you compare with singletons, a monozygotic pregnancy, twin pregnancy, would have the same aneuploidy risk as singletons, whereas dizygotic, the fetus risk is going to be the same per fetus, but because you have two fetuses, the overall risk for the pregnancy would be double the risk of a singleton pregnancy. Now, this is a logical conclusion that we tend to draw from this statement. However, logic is not always right. We need to understand and consider the fact that aneuploidy risk screening, if you look at an aneuploidy screening report, it would say the risk at term or risk at birth as a final report, as a final risk. It's not the risk at the time of screening that is calculated, but it is the risk at delivery or at term that is calculated. And we know for a fact that there is an increased risk of fetal loss that is associated or inherent with twinning. So this has to be factored into your risk calculation. And therefore, when you factor that in, there is robust data that says the risk per fetus for aneuploidy is actually lower in multiples, the relative risk being 0.58. So now, if you consider this into the risk prediction model, for monozygotic twins, the risk would be 0.34 in N if you assume that 1 in N is the risk for a singleton pregnancy. For a dizygotic, it will be 1.34 times that of a singleton pregnancy and not double. We said initially the risk is expected to be double, but because of this increased risk of loss of twins during pregnancy, the risk at term would not be as high as in singletons for both monozygotic and dizygotic twins. Now, the problem that we have is we don't look at zygosity as Sudarshan very clearly mentioned. What we see on scan or what we can identify on scan is not the zygosity, but only the chorionicity by looking at the lambda signs and the T signs as was very vividly described. So what then is the relationship between chorionicity and zygosity, or how do you extrapolate zygosity to chorionicity as far as screening is concerned? Now, as long as the placenta stays single inside the uterus, things are very, very simple. 100% of your monochorionic twins would be monozygotic. So you can extrapolate monochorionicity 100% to monozygosity. But it is when the placenta decides to get wedded to another one within the uterus that problems start. When you have two placentae, you have a dichorionic pregnancy, 90% of them would be dizygotic, but there would be a 10% fraction that is going to be monozygotic. You heard again from this from this slide that we showed before, that if the zygote, the monozygote splits before morula formation or day 4 of embryogenesis, then you would end up having a dichorionic but monozygotic twin. So 10% of all dichorionic pregnancies would be monozygotic, and therefore that extrapolation does not work as good as it does with monozygotic pregnancies. So how does this reflect in screening? Well, thankfully, there is enough data to prove the fact that for the purpose of screening, you can consider chorionicity and zygosity as one and the same. So obvious next question, I'm sure, would be what happens to the 10%? Now, the 10% from an epidemiological perspective is considered too small a fraction to affect the overall screening performance. You can ignore the 10% and equate a dichorionic pregnancy to a dizygotic pregnancy. And even if you do that, you are only erring on the positive side. If you call a dichorionic pregnancy as dizygotic, even if it's monozygotic, you are only going to overestimate the risk, not underestimate it. So you're allowed to consider dichorionics as dizygotics for purposes of screening. Therefore, the bottom line here is the screening, all monochorionic twins are invariably monozygotic. There's no confusion or ambiguity there. All dichorionic twins may be considered dizygotic, not accounting for the 10% fraction that's going to be monozygotic. So you could consider chorionicity as the true surrogate of zygosity for the purpose of screening. The next challenge is about labeling of twins. We said it's very important to label twins and identify them correctly for subsequent follow-up scans, especially if the results of your screening test are going to be discordant. So it makes sense to label them properly at the very first visit so that there's no confusion later on during pregnancy. So how do you label twins? Now, the convention practice is to label twins as per the expected birth order. In other words, the fetus that is likely or expected to be born first during delivery is labeled as twin A. Let me give you two examples here. On the one on the right, on the screen's right, you have a membrane or intertwin membrane that is aligned horizontally. Now here there is no confusion. It's very, very obvious that the baby marked, the baby colored in blue will be the first one to deliver during birth. And this would be the second one to come. So there's no confusion. This is labeled as A, this is labeled as B. Unfortunately, only 10% of twin pregnancies will have a horizontal membrane orientation. Whereas in the other 90%, the membrane is going to be aligned vertically in relation to the long axis of the uterus. Now here there is a problem. You have two twins lying here. This fellow is closer to the cervix, and therefore you would expect that this baby would come down during delivery. But look at the sac. It is the sac of the blue baby that is overlying the cervix. So if you do an ARM or if there's a spontaneous rupture of membranes, it's very, very likely that this sac will rupture first and this baby's head is going to come down and deliver. So in that case, it becomes very, very important to identify the point where the membrane inserts in relation to the cervix. This insertion point of the membrane is going to tell you which is the sac that overlies the cervix, not the feature that is important. The sac that overlies the cervix is important for purpose of labeling because that baby is going to be born first. So here in this example, you would label the blue one as A, even though it's higher up, and this as B. Let me give you an ultrasound example for the same. Here is the pregnancy that we saw recently. You can see that there is a membrane that's lined horizontally. Remember that this is the long axis of the uterus. The alignment of the membrane is parallel to that. So the vertically aligned membrane here, you can trace the membrane all the way down. And you can see that even though this baby lies to be overlying the cervix, the membrane is inserted somewhere here, making it very clear that this is the sac that is overlying the cervix and not this one. So hence I've labeled this as A, even though this is a baby that's obviously lying close to the cervix. This baby is nowhere in the picture, but because it is this sac that overlies the cervix, I've labeled this and this is B. Now, sooner rather than later, the baby is going to come down and occupy the lower pole of the uterus. So this point is what I had marked in the picture earlier. The point of membrane insertion is very, very crucial when labeling twins. Label the sac that overlies the cervix as A and the other sac as B. Now, you could also make it a point to label as descriptively, as vividly as possible by using as many other adjectives as you want to. Here is an example. You could call the fetus A as smaller, to the maternal left, occupies the upper pole of the uterus, has an anterior placenta, and the echogenic intracardiac foci. So this makes it very, very vivid in your description. So one of these at least is going to help you label correctly when the lady comes back for the subsequent visit. So make it a point to label it as descriptively as possible. Use as many pointers as you can get. And if it's a dichorionic twin with a discordant gender, things become easy. Even though you cannot report it on the scan report, you can always note it down on your internal comments. This is going to be very, very helpful in subsequent pregnancies, even if the positions of the features keep switching, as is something that can happen, as we all know. We have seen about the interplay between chorionicity and zygosity. We have seen how to label twins properly. Now comes the choice of the right screening test. Now, what are the options that we have? Just as we have for singletons, you have options of age-based screening. You have the option of adding on nuchal translucency to the age-based screening. You can add on additional markers like nasal bone, ductal venosus, and tricuspid regurgitation. You can throw in blood tests to the mix. You can do a first trimester biochemical screening or a second trimester quadruple test is an option. You also have the new and fancied option of the non-invasive prenatal testing or the cell-free testing. So let's look at each of these in a little more detail. Now, age-based screening, of course, we know is out of question. We never practice age-based screening. We always at least add on nuchal translucency we did in the first trimester scan. So let's look at how NT-based screening performs. Now, remember, you don't have separate normograms for twins as far as NT values are concerned. The centiles chart of the normograms are the same that used for singletons. This is because the NT distribution in twins is very, very similar to that of singletons. And you would expect a baby with Down syndrome, even if it's part of a twin pregnancy, to show an increased nuchal translucency as you would expect with singleton pregnancies. But the problem is you have two NTs here. You would have an NT for fetus A and another NT for fetus B, and most likely they're not the same NT values that you get in these two twins. So how do you use them in screening? Now with the monochorionic, we said you cannot have separate risks for the two fetuses. It has to be one common risk per pregnancy. So what you have to do with the two NT values is to simply add them up and divide by 2 or take the arithmetic mean. So you average the NT values and then use the normograms for singletons and give one single pregnancy specific risk. Whereas if it's dichorionic, you have two NT values. We know that the risks are going to be different for two babies because they are dizygotic twins. So the NT-based risks are calculated independently, and then you give a risk for each of these fetuses. The fetus-specific risk for dichorionic, pregnancy-specific risk for unichorionic pregnancy.
Vivek, your volume is going down suddenly.
Okay. I've not done anything different. Is it okay now? Hello?
Yeah, better.
Okay. Now, the question that is often asked is, in a monochorionic pregnancy, do you average the NT value or do you average the risk at the end? Now, both of these are acceptable algorithms. There are different platforms that use either of these. And which of these is better is still an unresolved question and requires a larger consensus. But whichever of these algorithms you use, remember that you have to give a pregnancy-specific risk and not separate risks for each fetus as with the dizygotic risk. Now, a couple of considerations when you consider NT-based screening in twins. We have to remember and account for the fact that the prevalence of an increased NT is going to be higher in twin pregnancies than with singleton pregnancies. Now, this is not because the risk of aneuploidy is higher. We said the risk of aneuploidy is in fact lower in twins than with singleton, but the prevalence of an increased NT is higher because we have a lot of other factors that account for it, like an increased incidence of twin-to-twin complications, increased incidence of congenital anomalies, increased incidence of congenital heart defects, and so on and so forth. The other point that we need to remember is that there's almost always a correlation between the NTs of a twin pair, particularly if it's a dichorionic pregnancy. Now, this has been reported in multiple studies, and the implication of this is if you see a dichorionic pregnancy where both fetuses have an increased NT, an NT above the 99th centile, it's more likely to represent a familial tendency towards increased nuchal fluid rather than both babies being abnormal. We know that the chances of both babies being abnormal in a dichorionic pregnancy is extremely low. Therefore, if you find increased NT, this could be a familial tendency rather than a pointer to an aneuploidy. But of course, you would want to rule it out. But this should come into consideration when you counsel these couples and not unduly scare them that there is a very high chance of aneuploidy. So what is the efficacy of nuchal translucency-based screening? We know in twins, in singleton pregnancies, it is as good as around 75%. And if you look at data from cross-sectional studies for twins, it is pretty much as good as comparable to singletons. You get a detection rate of around 75% for NT-based screening for a 5% false positive rate, and which is why a lot of guidelines recommend that NT-based screening is an acceptable first time for screening test for aneuploidy in twin pregnancy. Now, how about doing an additional marker? Well, nasal bone, of course, the overall results are similar from a lot of studies, so you can use nasal bone if you're pretty much confident in documenting and imaging both the nasal bones very, very distinctly. But remember that assessment could be slightly more difficult because of unfavorable fetal positions and so on. But if you manage to get a good nasal bone, you can, of course, use it in screening. Not so for DB and TR, because ductal venosus and tricuspid regurgitation are going to involve the fetal circulation of these things. You know, specifically in monochorionic twins, there could be problems with circulatory imbalances between the two. There is an increased risk of congenital heart diseases. You would not really want to rely on markers that are dependent on fetal circulation like DB or TR. So yes, you can use nasal bone, but the DB and TR, you don't have the same luxury. We've seen NT-based screening. Now let's look at combined test in twins. Now, combined test, you add in pre-beta HCG and PAPI in the first trimester. Let's see how this fares. Now, there are a few problems because once you add biochemistry to the mix, you're going to have problems because biochemical markers, unlike ultrasound markers, cannot differentiate between twins. It will be common for the pregnancy, common for both twins, and this could be a problem when you're discussing dichorionic twins. Secondly, we have to understand that because there's more of placental tissue, both of these beta HCG and PAPI are placental hormones, and therefore your marker levels are going to be obviously higher. So you would have to make sure that correction factors have been accounted for while calculating the risk for your software. If you do not mention that the pregnancy is a twin pregnancy, if you do not tick the right boxes when you choose the test request form, it might not make these correction factors. So you have to be very, very careful there. And the third point, of course, is that in dichorionic twins, if they're discordant for aneuploidy, the abnormal value from the abnormal twin could get masked by the normal values of the normal twin. So you might end up not picking up an abnormality if you do serum-based screening there, which is why most of the earlier literature suggested that the screening performance of the combined test is pretty much similar for dichorionic twins, but it's substantially improved when it comes to monochorionic twins. The dichorionic twins, H plus NT versus combined test is not particularly different. You get probably a 2% increase in the twins. However, if you look at more recent evidence, this is from a 2014 meta-analysis, this meta-analysis says that the detection rates are comparable irrespective of the chorionic. You get up to 86% detection rate even in dichorionic. This is a large meta-analysis for a fixed 5% false positive rate. If you are to go by recent evidence in twin pregnancies, to choose between NT-based screening and combined screening, you can definitely opt for the combined screening test because it gives you not just higher detection rates, but also decreases the false positive rates. So there's no question, if you can do a combined test in twins, irrespective of the chorionicity, the combined test should be your first choice for screening in the first trimester.
Dr. Vivek, another 2 minutes to wind this.
Yes. So how about NIPT? Now, NIPT, again, there are a few concerns because cell-free fetal DNA in maternal circulation would be from both twins, so you would not know which baby is affected should there be a problem. Validation data is mostly based on singleton studies, so you don't have enough robust validation data for twins. And again, even though the total fetal fraction is going to be higher because you have 2 placentae or a larger single placentae, individual fetal fractions would be lower because the 2 placentae is not the same as 2 separate placentae. Even in the monochorionic twins, you would get only around 1.6 times the size of a single twin placentae. So the individual fetal fractions are going to be lower, and therefore, obviously, we know that no-call rates or failure rates could be higher as well. However, a lot of these concerns were laid to rest by these two huge meta-analysis that came out very recently. This one as late as March 2021 from the Fetal Medicine Foundation, where they said that the detection rate for trisomy 21 at least is as high as 99%, with a narrow confidence interval from 92 to 99.9%. You can really use the NIPT as far as Down syndrome is concerned, but not so much for the others because you see a very wide confidence interval there. So even though the detection rates are not very poor, for trisomy 18 and 13, the confidence intervals are very, very varied and wide, and you would not rely on an NIPT to diagnose abnormalities of trisomy 18 and 13 in pregnancy. But for the case of Down syndrome, for example, if you've done a first trimester screening test, it shows an intermediate risk or probably even a borderline high risk for Down syndrome. The patient does not want an invasive test. Such conditions, even if it's a dichorionic or a monochorionic twin, you could use NIPT as a contingent screening option. So the implication in practice is, like you use it for singletons, you can very well use it in the contingent screening model for Down syndrome, even in twin pregnancies. Second trimester, don't even think about it because the detection rates are very, very low. The false positive rates are unacceptably high. So for twin pregnancies, a triple test and quadruple test should never be an option unless you've missed the screening window in the first trimester. Now, what invasive testing would you choose? Again, of course, the best choice would be to do a double amniocentesis because that will give you the best answer without ambiguity. You have to be sure that both babies are normal. So the best choice there would be a double amniocentesis, a 2-puncture amniocentesis. And remember that sampling errors are higher with CBS, so always amniocentesis would be the preferred route. And even if it's a monochorionic pregnancy, you're not sure of the monochorionicity, always safer to sample both sacs. But if you're very, very sure that it's a monochorionic pregnancy, you've seen her in the first trimester, documented the P sign, then probably, and if the babies are concordant in growth like Doppler's hand structure, then maybe you might get away with doing just one amnio. But otherwise, any condition where there's a doubt, any situation where there's a doubt, it's always safer to sample both the sacs. Last slide on vanishing twins. Now, vanishing twins is not an uncommon phenomenon. In fact, with ART pregnancies, it's as high as 38%. Now, the problem with vanishing twins is that the markers, the biochemical markers in the dead twin could persist for a lot many weeks after the twin dies in utero. So this can interfere with your interpretation of biochemical values. Now, this particularly applies to PAP-A because PAP-A values, in fact, unlike what was thought previously, tend to increase after one baby dies in utero. So if you do not account for correction factors there, using PAP-A can completely throw your screening algorithm out of gear. Now, the same does not apply to pre-beta HCG. Pre-beta HCG is fairly constant, even if you have a dead fetus, dead pole there, or if you have an empty sac. Irrespective of whether the fetal pole is there or not, pre-beta HCG values do not alter even after the death of one twin. So in vanishing twins, take-home messages, pre-beta HCG does not change, PAP-A values increase. So the ideal screening option there would be to combine NT with beta HCG and leave out PAP-A screening. You have to instruct your lab to not use PAP-A while screening them, but you can certainly use NT and beta HCG. This gives you better detection rate than choosing NT alone. Now, if your lab is not well versed in doing that, just go by NT-based screening. Do not go for combined tests with PAP-A because PAP-A values tend to be higher even weeks after the demise of one fetus or of the vanishing twin. Now, cell-free DNA, not even in question for vanishing twins because it has been documented that fetal DNA from the dead twin can persist for at least 15 weeks after the death of one twin. So by then you would have reached the second trimester. There's no question of applying screening by NIPT twins. So take-home messages, aneuploidy screening is related to zygosity and only to zygosity. But because it's chorionicity that we've seen and because chorionicity is not drastically different from zygosity, you could use chorionicity as a very effective surrogate for the purpose of screening. Monochorionic twins, remember the risk is per pregnancy, and dichorionic, it has to be the risk per fetus. So if you see a report of a monochorionic twin, which is reported separate risks for both the fetuses, send the report back to the lab, reconfirm that it is a monochorionic pregnancy and ask them to recalculate the risk. Do not accept a screening report that gives you separate risks for monochorionic or a single risk for a dichorionic pregnancy. Now, we said that actual risk at term would be lower in twins than corresponding singleton pregnancy because of the increased risk of fetal loss that is inherent to twin pregnancies. We found out how crucial and how important it is to label things very, very descriptively so you don't miss out on labeling them in subsequent scans. NT-based screening is comparable to that of singletons, but given a choice any day, you would want to add beta HCG and PAP-A because this gives you much better detection rates and lesser false positive rates. Second trimester serum screening, very low detection rates, very high false positive rates, and not acceptable unless in exceptional circumstances. And NIPT can be used as you use for singletons in a contingent screening model, extremely promising for Down syndrome, not so much for trisomy 18 and 13. So in a contingent screening model, to avoid an invasive test, probably you could rely on an NIPT. As far as invasive concerned, we clearly said that 2-puncture amnio is the best invasive option unless you're absolutely sure that it is a monochorionic pregnancy and the twins are concordant for everything. Lastly, vanishing twins, don't just go with NT alone. If your lab can incorporate beta HCG, add on free beta HCG because it significantly pushes up the detection rates and decreases the false positive rates. But do not use PAP-A because PAP-A values can persist higher for quite a few weeks after the single fetal demise. NIPT definitely not recommended because the DNA can persist for up to 15 weeks later. Thank you.
Thank you, Dr. Vivek Krishnan. I think as obstetricians, we are all so lucky that we have plenty of fetal medicine experts so that the challenge of handling multiple pregnancy and the aneuploidy concerns, you have very nicely elucidated the role of how we use the NIPT or the serum markers and then take the right decisions. So, however, I would just request you, like when the interaction session, either your fan or your double gadget around is disturb the audio effect of your presentation. So just verify that. So otherwise, I think we learned so much from you and we're so happy to have fetal medicine people to take responsibility of the challenges involved in diagnosing aneuploidy.
Thank you, Dr. Rajapriya. Thank you, sir. May I now request Dr. Jayashree Gajraj, Madam, to introduce our next speaker for this session, Dr. Tony Khan.
Good afternoon to everyone. I would like to thank Dr. Vijayalakshmi Seshadri and Dr. Umaram and the entire team at OGSSI for inviting me to chair this session, and especially privileged to introduce Dr. Tony Tan. A warm welcome to him. Dr. Tony Tan is the director of the Tony Tan Women and Fetal Clinic at Mount Alvernia Hospital. He has been the president of the OG Society of Singapore from 2013 to 14, chairman of the Maternal Fetal Medicine Committee of AOFOG, medical director, Alvernia Obstetrics Screening Center, consultant, Department of ONG at KK Women's and Children's Hospital and Raffles Hospital, Singapore. Having graduated from the National University of Singapore, he trained in fetal medicine, including twin pregnancies, at Queen Charlotte's in London. He is a fellow of the Royal College of Obstetricians and Gynecologists in the UK and Academy of Medicine, Singapore. Member of the Royal Australian and New Zealand College of ONG, examiner for the MRCOG examinations and the exec examinations for the trainees in Singapore. Thank you very much, Dr. Tony, for joining us. We look forward to listening to you. Having had this wonderful dialogue on chorionicity and a talk on aneuploidy screening, we now move on to prevention of preterm labor in multiple pregnancy. Bad enough in a singleton gestation. When we talk of multiple, we know it's a nightmare for us. Thank you very much for joining us. The floor is yours.
Thank you. Can you see my screen?
Yeah, we can see your screen, certainly. But I think you'll have to go to full screen, to slideshow.
Okay.
Yeah, that's great.
All right, thank you. Thank you for the introduction. I'm going to talk about prevention of preterm labor in multiple pregnancy, what works. So I'm going to tell you 8 stories in total. Some of these stories work, some of these stories don't work. Let's divide them into primary prevention and secondary prevention. So primary prevention is for those all twin pregnancies, and secondary prevention are for a group of twin pregnancies. In primary prevention, I'm going to talk about bed rest, low-dose aspirin, screening for asymptomatic bacteriuria, lockdown, and screening for bacteria vaginosis. So first intervention, bed rest. Well, it's something that all of us obstetricians prescribe with or without any evidence. But actually, there's some data to show that if we prescribe bed rest with or without hospitalization in twins or triplets, there's no difference in the risk of very preterm birth, perinatal mortality, and low birth weight. In fact, there's a study to show that it actually increases the risk of spontaneous onset of labor. Perhaps, especially if you keep them in a hospital, because then patients are actually stressed, doctors are stressed with all the monitoring, CTG abnormalities, you may end up delivering them earlier. Second intervention, there has been a study recently to show that aspirin reduces preterm birth in singleton nulliparous women. And I think it's interesting. Let's talk about this. So there have been a lot of studies about aspirin for the prevention of preeclampsia in healthy low-risk nulliparous women, where low-dose aspirin has been shown to reduce. And when we do secondary outcome measures analysis, we found that actually it reduces the risk of preeclampsia, but it also reduces the risk of spontaneous preterm births in the nulliparous women in the singleton pregnancies. And when you look at the meta-analysis, it also shows where if you start your aspirin below 16 weeks, it actually reduces the chance of preterm births. However, the consensus statements from ACOG and SMFM in 2018 is saying that aspirin for the use of prevention of spontaneous preterm birth is not recommended in the absence of risk factors for preeclampsia, because there was no direct study to show this. This has changed with this publication in the Lancet last year, where a study called the aspirin trial, aspirin supplementation for pregnancy indicated risk reduction in nulliparous, where 11,000, almost 12,000 women were studied, nulliparous singleton women. Aspirin 81 milligrams were given starting from 6 to 13 weeks to about 37 weeks. These were mainly done in low and middle income countries. And actually, it shows a reduction in preterm delivery from about 13.1% to 11.6%, about 11% reduction in the risk of spontaneous preterm birth. So it works, seems to work in singletons. Should we then start to use aspirin to prevent preterm birth, preterm labor in twins? It is. I'm a bit cautious about this because even the use for singletons has not been accepted by the international colleges for use yet, and we do not actually have evidence of usage, evidence of that it is useful in twins. And therefore, my own position on this is that maybe we should wait for further evidence and further consensus on the use of aspirin before we use them in more patients. Now, the third intervention, of course, a lot of us are already doing this. We screen the patients for asymptomatic bacteriuria at booking, and then we give antibiotics for those who are. And of course, this happens in 2 to 15% of pregnancies. And if untreated, it increases the risk of acute pyelonephritis as well as preterm birth. So this Cochrane trial in Cochrane study in 2019 showed that if we use we screen for and treat the asymptomatic bacteriuria, we can reduce the chance of pyelonephritis from about 20% down to about 5%, as well as the preterm births from about 17.4% down to about 6%. So these are quite remarkable reductions. Of course, most of this data is in singleton, but there's no reason why it doesn't work in twins. Now, the fourth intervention is quite interesting. It's called the lockdown effect. And that's because a lot of studies recently from the lockdown effect, which has shown reduction in extreme preterm delivery. We don't know what's the mechanism. It could be most of the women are now working from home. Everybody is wearing masks now. Maybe they have less stress, less time to commute, and therefore they have enough time to exercise, enough time to rest. But really, if you look at the studies from Denmark, Austria, Israel, US, Ireland, even locally in Singapore, we asked KK and SGH, which are public hospitals, and the preliminary analysis seemed to agree that the lockdowns, during the lockdown periods, very preterm births seem to be reduced consistently through all these different studies. So this seemed to be the possible mechanisms: less commuting to work, less stressful workplace dynamics, more sleep, more rest, increased access to family support, less physically demanding work, exercise. Everybody wears masks, less exposure to air pollution, tobacco, and illicit drugs, and maybe an avoidance of financial strain. Now, the fifth intervention is screening for bacterial vaginosis and antibiotics. And again, in singleton studies especially, there's a strong association between the presence of bacterial vaginosis and preterm births before 37 weeks. And especially if the bacterial vaginosis is identified before 16 weeks. And there's a strong association between BVs and late miscarriages as well. So there are a few randomized control trials to say that if you give clindamycin, it seems to reduce the risk for bacterial vaginosis. So in the Lancet 2018, there was this Primiva trial where 84,500 low-risk pregnant women were screened before 14 weeks for bacterial vaginosis. They pick up 5,600 women who are BV positive, and they treated 3,000 of them. And they give them clindamycin 300 milligrams BD for 4 days, followed by, or clindamycin 300 milligrams BD for 4 days per month for 3 months versus placebo. And unfortunately, in that trial, it didn't show any reduction in preterm births. So really, the consensus guideline is we do not screen for bacterial vaginosis in pregnant persons, whether singleton or twins, for the purpose of prevention of preterm birth. If a patient has symptoms with smelly vaginal discharge, of course you do a swab. If you pick it up, of course you treat it, but we don't screen them because screening and then treating them has not been shown to reduce the risk of preterm births. Now we go on to secondary prevention, which is probably more interesting. We're going to talk about progesterone, cerclage, as well as this cervical pessary. Let's talk about progesterone. And giving progesterone seems to quiescen the uterus, seems to prevent the ripening of the cervix, maybe modulate the production of the cytokines by the amniotic epithelial cells. And the two common formulations that we use is IM17 alpha hydroxyprogesterone caproate. It can be given weekly from 16 to 20 weeks, as well as vagina progesterone, 200 milligrams ON from 20 weeks to 36 weeks. Let's talk about this injection. There was a trial for singletons in June 2003 in New England Journal, where there was 463 women with past history of spontaneous preterm delivery, and the injection weekly seems to reduce the risk of preterm births below 37 weeks, below 35 weeks, below 32 weeks. So that led to the US using this for a lot of patients who have got past history of preterm birth. And it was marketed under the trademark of Makina, and the company actually charged a lot of money for that drug. And the FDA actually insisted that they had a follow-up study, and they followed up by doing this prolonged study on the group of patients who had been given this amproduton. And unfortunately, in this trial, of which 41 were done in the US, 52 outside the US, they found that in patients who had spontaneous preterm births in singleton pregnancies, it did not show any reduction in preterm births at all in those who were given. So that led to the FDA not approving the drug anymore, and it seems that it doesn't work. Well, for the purpose of twins, this IM injection in different studies have shown no reduction in preterm births, no difference in average gestational age at delivery. It does not have different concentrations when compared to singletons. It is, in fact, when we give double the dose, 500 milligrams twice weekly in twins, it was paradoxically associated with an increase in preterm births. In triplet pregnancies, it doesn't increase there's no benefit, and in fact, there's a possibility of an increased risk of perinatal mortality. So for twins and triplets, please don't use this IM injection. Let's go on to vagina micronized progesterone pessaries. And Nicolaides actually published something very recently, January this year, of 1,173 women, where they gave vagina micronized progesterone 600 milligrams per day from 11 to 13 weeks after the first trimester scan to 34 weeks in all twins, and it does not reduce the risk of preterm births. In a post hoc analysis, they show that maybe it reduces the risk of spontaneous preterm birth labors in those where the cervical length done at 12 weeks is less than 30 millimeters. However, if you look at the 95% confidence interval, it crosses 1, and even then, that is not statistically significant. Therefore, I guess to use it in all twins doesn't make sense. In fact, if you use it when the cervical length is more than 30 millimeters, the risk of preterm birth seems to be increased paradoxically. However, if we identify a group amongst these twin pregnancies where the cervix is short, less than 25 millimeters at about 20 weeks, we find that vagina progesterone reduces the risk of preterm birth less than 30 to 35 weeks. Also neonatal mortality and some measures of neonatal morbidity without any demonstrable deleterious effects on the childhood neurodevelopment. Let's go on to cervical cerclage. So the commonest cerclage we do is, for this is the McDonald cerclage. Some people do the Shiroka as well. So do we use it in all twins? No, because if we use it in all twins, it has been shown to cause more preterm births, in fact, So really, there are only 3 indications for use. One is a past history of spontaneous preterm labor, or a past history of preterm prompts, or of course a history of cervical insufficiency where you have painless mid-trimester losses. That would be a clear indication for cerclage even in twins. Physical examination, meaning if you put in a speculum, see that the cervix is dilated at least 1 to 2 centimeters, 1 to 4 centimeters, you might want to put a cerclage in. And what about if the cervix is short? Do we put in a cerclage? We're going to examine all 3 indications. Of course, we all know that the risk of cervical cerclage is up to 15%, where you could sometimes not be able to cerclage it if the cervix is already fully dilated. You may rupture the membranes inadvertently, it could lacerate the cervix, it could bleed, it could induce contractions. Well, in 2014, in the Cochrane study where they published, where they analyzed 5 randomized controlled trials involving 122 twin pregnancies and 6 triplet pregnancies, there was no decrease in preterm births. There was another trial at the time in 2016 where when the cervix is, this wasn't a randomized controlled trial, it was an observational data. When the cervix is dilated at 1 to 4 centimeters between 16 to 24 weeks, 38 cerclages were done versus 38 controls. And in this study, it showed that it actually prolongs the pregnancy. So these two databases were used in a lot of the college guidelines, in the Canadian guidelines, as well as the American guidelines. And basically, it's quite clearly stated that cervical cerclage is not recommended for all twin pregnancies, even if there is a history of preterm births, or even if the cervix is short. And the only exception, because of the Roman trial, was that if the cervix was dilated before 24 weeks, maybe there is a role for cerclage. And since then, since 2019, there have been a few publications about cerclage in twin pregnancies, and we are going to review this data to then form our own opinion from here. So in the Lee et al. In a systematic review in 2019, at that time there was only 1 study, a randomized trial about patients, twin pregnancies with a past history of preterm births. And in that trial, they found actually no evidence of any advantage. However, recently in the ultrasound ONG in 2019, this author actually showed data of 41 cerclages, more than this randomized control trial, versus 41 controls. And they found that actually cerclage in this group seem to have less reduction, less preterm from less than 34 weeks, as well as less preterm delivery below 34 weeks, 32 weeks, 28 weeks, and 24 weeks. And the data here looks quite promising. So this is a randomized controlled trial. This is not a randomized controlled trial. I guess the jury is still out. The correct answer is that we really need more data before we know what's the next step to do. Now, this was the Roman trial we were talking about in 2016, where if the cervix is dilated 1 to 4.5 centimeters at 16 to 24 weeks, we find that the cerclage seems to reduce the risk of preterm birth at the different cutoffs. And also, since you are able to prolong the pregnancy, it seems to reduce the risk of severe neonatal outcomes. When Lee et al. Did the systematic review, including the Roman trial, they found that there was some evidence that it worked for before 32 weeks and below 32 weeks on. Sorry, below 34 weeks on. Yeah. And since you're able to prolong the pregnancy in that group, again, reductions in the respiratory, in the morbidity to the baby. So because these were all observational studies, Roman et al. Went on to do a randomized controlled trial. and published it in American Journal of ONG last year. And it was a randomized controlled trial. Unfortunately, this trial was prematurely terminated. And the reason it was prematurely terminated after only having 17 cerclages was that already at that time, there was evidence that the cerclage reduced premature births, and therefore the ethical board felt that it was necessary to stop the trial to prevent any harm to the group that were not given cerclage in this group. We find that the cerclage was able to prolong the pregnancy by at least about 5 weeks plus compared to no cerclage. And this is with cerclage, this is with no cerclage, and you can see that from 2 to 3 weeks after the procedure, you already see an advantage. And the next group is in the ultrasound indicated cerclage, and you find that where the cervix is less than 25 millimeters, should you do a cerclage or not? And the data really isn't very clear. Not so clear until they divided the cervical length and analyzed. And when they found that if you use less than 25 millimeters, the effect is not statistically significant. If you look at 16 to 24 millimeters, again, no difference. But if you limit yourselves to the cervical length less than 15 millimeters, you find that there was a reduction in preterm births below 37 weeks, below 34 weeks, below 32 weeks. Therefore, the authors actually did a good summary of this, that if it's more than 15 millimeters, cerclage, probably not useful. Less than 15 millimeters, probably useful. So these are diagrams you can look at. More than 25, 15 to 25 mm, not good. Less than 15 mm or the cervix dilated, these two groups are good. The last intervention, cervical or cerclage pessary. This is the Arabin pessary. We don't have it in Singapore. I'm not sure whether India you have it available. And it's been used to try and prevent preterm births in twins. Nicolaides has done a study, pro-twin study in Lancet 2013. These were unselected twins and they found no evidence of any benefits. In the Perceps trial, twins by Goya in the Spanish teams, the cervix less than 25 mm, it seems to reduce the chance of spontaneous delivery before 34 weeks. However, if you group them up in the meta-analysis, looking at those where the cervix are short, even in the Nicolaides group, you find that the effect is not statistically significant. So I think it's not widely accepted that the cerclage pessary works for prevention of preterm births in twins. So in summary, for twins, if you have a past history of preterm labor with normal cervix, really you have two options. If you believe in the data that maybe it works, you can offer a cerclage. If you don't believe in the data, monitor the cervical length closely, cerclage it if the cervix is shortening, or if the cervix is less than 15 millimeters. If your cervix is short, between 16 to 25 millimeters, offer vaginal micronized progesterone, 200 milligrams once a night, and then do weekly cervical length to 24 weeks. And if the cervix shortens below 15 mm, do a cerclage. If your cervix is less than 15 mm or cervix dilated more than 10 millimeters, offer a cervical cerclage. So we've gone through these 8 intervention stories. Bed rest doesn't work. Screening for BV doesn't work. The injection doesn't work. Pessary doesn't work. Aspirin, well, no data. I put a question mark here. So really, what do we have now? We have screen for UTI, maybe advise them to wear masks, not to work so hard, be less stressed, measure the cervical length. If the cervical length is between 16 to 25 millimeters, offer vaginal micronized progesterone, 200 milligrams. And if the cervix shortens less than 15 mm, or if there's a potentially past history of preterm labor or dilated cervix more than 1 centimeter, you may want to offer a cerclage. I just want to conclude that it's hard to practice evidence-based medicine, especially for the prevention of preterm birth, but we try. And thank you for your attention. And take care. I know COVID is back to India.
Thank you very much, Dr. Tony, especially your last slide where you've been very honest.
Yeah.
But excellent analysis of all the possible interventions. You took us through, the trials with the evidence you were able to tell us, and your emphasis on the downside of bed rest, which is, I think, a very important message that we need to give to our own colleagues. And I liked your comment on the lockdown as well. So thank you very much. We've enjoyed the talk. Thank you.
Meenakshi, couple of questions allowed?
We'll have a poll now, and then the questions for the speakers. Yeah. Sorry, Meenakshi, take over.
Not a problem, ma'am. So can we start with the polls, and
Yeah.
Deepan sir, you can. Can we go to the first question, ma'am, the poll?
Yeah, we want everybody to respond. You can click on the poll.
Yes.
We have 200 participants, so I would like to see 200 responses.
The absence of a twin peak or the lambda sign at 20 weeks of gestation confirms dichorionicity. You need to say true or false. "30 seconds. I'm sure Meenakshi is counting.
Yeah, it is flashed on the screen. The poll is closed.
Okay, we move on to the next question. Yes, the absence of a twin peak or lambda sign at 20 weeks of gestation confirms dichorionicity. And you should say true or false, and you can see the answer. Yes, we'll go on to the second question.
Meenakshi, second question has to be projected.
They're flashing the answer. Yeah. Okay.
Yeah, they just flashed the poll results, ma'am.
Poll response. Okay. Okay. So here, assign chorionicity based on this ultrasound picture, whether it's monochorionic diamniotic, monochorionic monoamniotic, or it's diamniotic.
Yes.
A little bit more time. I think only about 30-40 people are voting.
Can we have more people vote for this? I see about 183 logged in. The poll is closed. About 66 people have voted.
Okay, we'll have the answers now. Okay, so the answer is monochorionic diamniotic. I'm sure you saw the single placenta and the amniotic sac out there. They have the dividing membrane in between. So anyway, the number of people attempting are lesser. Maybe they're not used to it. Okay, so the answer is monochorionic diamniotic.
So I think we have 73% of them who have clicked on the right answer.
Good. So that means the questions have made sense. And I've got a question to Dr. Tony Tan.
How to put Poli?
When the poll is launched, you'll have an option to answer on the poll.
There will be a pop-up on the screen, ma'am. So you can answer on.
That's disappearing a bit too fast, I think. You were going to allow 30 seconds or?
It was 30 seconds, but I think it just moves very fast by the time we read the question. Chitrakala, you can start the timer after the question is probably
able to.
Yeah. Yeah. Okay.
Yeah, Dr. Rajapriya is ready for the next two questions. You can move on to question 3. Please start the timing after the question is read.
In a DCDA twin with one sac having a non-viable fetus, what is the option you will choose? This is with respect to the aneuploidy testing. Would you choose NT-based screening, combined test, NIPT, NT with beta-HCG, or NT with PAP-A?
Yeah, the poll results have been shared.
This is the poll result. Finally, we will know the final results where we'll know the correct answer. So the poll result is more in favor of the NT with the beta HCG.
They've been listening to the talk. Next poll.
Can we
given actually adequate time, I think, the 30 seconds. The next question on aneuploidy screening again. When you get a fetus specific risk in a twin pregnancy, would you think it's a monochorionic twin or a dichorionic twin? This is a fetus specific risk. Lovely. So majority have given it as a dichorionic twin, and that's a fetus specific risk.
So we have two more questions. Jayashree madam will be taking those two questions. Can we flash question number 5?
So question number 5, which of the following strategies to prevent preterm labor in higher order, to prevent preterm labor in higher order multiples, that's more than 3. Weekly IM 17 alpha hydroxyprogesterone caprate 250 milligrams weekly from 16 weeks onwards. Daily vaginal micronized progesterone 200 milligrams once a night from 16 weeks. Cervical cerclage at 12 to 20 weeks. Bed rest or fetal reduction. You can start the timer.
The poll is closed. I think only about 14 people have voted this.
Have voted. Is it fatigue setting in? Tea time? Okay, I think this shows that 71% of the small number who have voted shows fetal reduction. I think fetal reduction is the correct answer, but I'm sure it will be discussed later. Let's move on to question 6.
Can we flash question 6?
Chitra, start the timer after Dr. Jayashree completes.
So there's quite a lot of options, so start the timer after I finish. Okay, which of the following strategies have been shown to reduce risks of preterm labor in twin pregnancies? Fetal reduction from 2 to 1. Weekly IM 17 alpha hydroxyprogesterone caprate 250 milligrams from 16 weeks onwards. Daily vaginal micronized progesterone 200 milligrams once a night from 16 weeks. Cervical cerclage 12 to 20 weeks. Prophylactic oral chocolytics. Low dose aspirin. Bed rest. You have quite a few options to choose from. So this seems to be the most popular question, am I right? There are quite a few people who have voted for this. And I think the answer, as most have chosen, is the daily vaginal micronized progesterone 200 milligrams. So we can move on to discussion.
Thank you so much, chairpersons, for taking up the questions of the audience poll. I request the audience to have more interaction during the subsequent polls. We would
Meenakshi, we have questions, Meenakshi.
We have a few talk. So if the something also you can add, sir.
Okay. I have a question for Dr. Tony Tan. I'm sure he's still there. Dr. I thought the slides on the bacterial vaginosis and clindamycin were perfect, but I thought the incidence of preterm labor was more with screening for GBS, group E streptococcus, rather than bacterial vaginosis. But then the yield in, we tried doing GBS screening, we could not pick up. Even if we screened 3,000 women, we didn't get even one GBS positive. So what is your opinion on screening for GBS as a method for prevention of preterm labor?
You do the GBS screen at 16 weeks or, okay. So
16 and 36 again, just before, yeah, the rectal swab, and we did try, we're not doing it. We're not doing it, to be honest. We did try that, but we didn't get any yield. And so we stopped the,
yeah, but you see, unlike the bacterial vaginosis where the observational data was very strong, and when there's BV, the risk of preterm births was very high. I don't think we have the same data connecting GBS and preterm birth. So if we do not have the observational data, I'm not sure that we should be jumping in to do intervention studies actually.
Thank you very much. So I do agree that screening for GBS didn't do a yield, but maybe BV was a better option. Yeah.
This is a question to Dr. Sudarshan or Dr. Shobna. One of you can take the first question and the other can take the other question. In monochorionic twins, is it always a problem for the other twin if one dies? Does the gestation matter? What other factors matter? Any of them, please unmute and speak. Dr. Sudarshan, Dr. Shobana?
Can we go to gallery view? Maybe we can see everybody then for the during the audience interaction.
They are in. I already checked that they are in, but maybe.
I think this is going to be discussed in the subsequent sessions also.
Because there's one more question for them. So if both of them are not there, I would read out, or somebody else wants to.
Maybe
no, I can. Now, I wasn't able to unmute.
Sorry.
Meenakshi?
Yeah.
So I saw the question in the chat. Yes, it is always a problem if one of the baby dies in a monochorionic pregnancy. We all know the pathophysiology. There is a profound hypotension in the healthy baby, and we can have neurological sequelae. Gestational age matters in managing. So we need to save the healthy baby before the other baby dies. So this may be by way of doing cord occlusion if it is early on in pregnancy, say less than 24 or 26 weeks. If it is more than 26 weeks, then we cannot do this procedure, and therefore we have to deliver the healthy baby out with preemptive steroids and magnesium sulfate for neuroprotection. This is in a nutshell. I'm sure this will be discussed along with the case discussion.
Yeah, the other question to the same, ma'am, why do many units not report chorionicity at early scan? What are the challenges, or is it a lack of awareness or training?
I don't know if Sudarshan is there. Sorry, Shobna. Go ahead.
Sudarshan is there.
Yeah, go ahead. Otherwise, if Sudarshan is not there, maybe Vivek or can take that question also along with you.
Yes,
so from the obstetric perspective, it's a very common knowledge that the chorionicity is the most accurate when it is reported at 12 weeks. I think we should rephrase this saying it should always be reported before 12 weeks. At 12 weeks, very good. Earlier than 12 weeks is even better. At 9 weeks, it is possible with a good quality ultrasound to report chorionicity. Even if we don't do at 9 weeks, we should try and do it at 12 weeks or before and not later than that.
Thank you, ma'am. Dr. Vivek, you can unmute yourself. There are a couple of questions for you. Do we have nomograms for biochemical testing in MCDA twins?
Yes, you do have nomograms. I mean, there are correction factors, as I said, that need to apply because the concentration of serum markers, the absolute concentration of serum markers would be high because you have either 2% or a percentage that is 1.6 times that of a single gene percentage. So obviously there are correction factors. I think for beta HCG, you need to divide the value by 2 point something. And for PAPA against by 2.19 or some value that like that is there. Fortunately for us, all those would be done by the software. So you just have to make sure that you spell it out on the test request form that this is a twin pregnancy, and you specify the type of twin pregnancy, and then the software will do the calculation for you. So there are different nomograms, and these nomograms have been incorporated into your reporting software.
All right. Thank you, sir. The other question for you is IVF done with pre-implantation screening and embryo implanted, then diagnosed as twins. Should we screen for aneuploidy? If so, what do we use?
If you've had a pre-implantation genetic screening done, the assumption is that both babies are chromosomally normal, intact. But we have had instances where patients have gone through pre-implantation screening for a known genetic disorder. They turned out at 11 to 12 weeks with discordant anomalies. We did a CBS and found Down syndrome in one of them. So I really am not very convinced about the prospects of pre-implantation genetic screening as it exists today. So we would not rely only on pre-implantation screening. We would definitely do, at least in aneuploidy screening, is not a CVS in the first trimester pregnancy.
There's one more question for Dr. Vivek. Meena, shall I say that?
Yes, please go ahead.
This is in this COVID times with lockdown, all that, a good lot of people miss out on the screening. So here you have a 32-year-old dichorionic twins. She's missed her screening at 12 to 13 weeks. So in this situation, would NIPT be a good screening to offer?
That's a difficult question to answer. Well, of course, if the financial implications are not so much and they are opting for an NIPT would be definitely a good choice. But the other option would be a quadruple test. As I said, the performance of a quadruple test for teens is quite low because the biochemical values can go that way. So it's not definitely the first recommended option, but if they miss the first trimester screening window and they're not affording an NIPT, then of course you can use this as a stopgap arrangement. The other thing that you can do is to rely on a good anomaly scan. The second trimester anomaly scan can pick up a good number of aneuploidy markers. If you find the markers, you can always use NIPT as a contingent screening option. Whether or not you should directly go for an NIPT, the first choice is left to the discretion of the parents. If they're affordable for the test and they want to go ahead with it, of course you cannot stop them from doing it. It is a good screening test, as I said, but not always an option for across the population basis because of its high costs. Such cases, you can rely on a good anomaly scan. If there are markers, and then you can of course apply the NIPT as a contingent screening option.
Thank you. Thank you so much, sir. I think Dr. Tony has been answering a couple of his questions in the chat box itself, but still for the benefit of everyone, I would just like to ask this. Do you insert a cervical stitch in twin pregnancies?
So when I was training, I was reading that cerclage and twin pregnancies don't go together. And so I was quite happy about the new data to show that actually it still works for cervix that are very short, less than 15 mm. So I do that for less than 15 mm if the cervix is open, or even if it is not less than 15 mm, for example, if the cervix at 20 weeks is 25 mm, and then at 21 weeks is 21 mm, and then at 22 weeks is now 18 mm, I actually worry that it's shortening despite progesterone so quickly. I may offer a cerclage as well. But I think where we are able to monitor them weekly, it makes sense that we be strict with the cutoffs and not do it if it's more than 15 mm.
Thank you, sir. There's just one more query that progesterones may not reduce the risk of preterm labor, but why should it increase the risk?
I think I don't know the reason actually, but I think especially the IVF doctors, they're really all into whacking the patient with all kinds of progesterone, right? Injection, vagina tablets, oral tablets. And I'm not sure that whatever they are doing is actually good for the patient. And I think you want to give back the progesterone, fine, but don't overdo it. And I think when you overdo it, just like when we had when people were giving estrogen during pregnancy and they, it caused trouble. I think when we just whack without good reason, we are now seeing that there are bad effects from that. But I don't know the mechanism.
Right. So there's also a question, which method of cerclage would you recommend?
I just do the simplest. I do the McDonald's. Yeah. But I think you do the method that you are most comfortable with.
All right. So I think we have taken most of the chat questions. If there's anything else from the chairpersons, otherwise we'll conclude this session. We are well on time.
So just one question to Dr. Tony Tan. Is there any particular reason why the pessary is not available in Singapore?
The Arabin's cerclage pessary is not. We don't have any pessaries. I started off being quite excited that maybe the pessary would be a replacement of the cerclage. And however, the singleton data has been not very promising. In the randomized control trial for its use in singletons, only the Spanish trial shows promise, and Nicolaides, Hong Kong, all have shown that it doesn't work. So therefore, I think if in total, you don't know why it works in Spanish in Spain and not elsewhere. But I don't know that there's any other centers outside of Spain that has consistently shown that it works. So because of that, we're not so. I guess because of that, we are not in a rush to bring in this cerclage, this pessary.
Dr. Tony Tan and Dr. Jayashree ma'am, I thought your neighboring country, Malaysia, uses the Arabin pessary quite well. And I thought we had a workshop a couple of years back, and they said we've never done a cerclage in the last few years, and we've been using only Arabin pessaries. So I'm just waiting your expert comment.
Well, I have no experience with the cerclage pessary, and the reason I'm not using it is because the data hasn't been clear. I'm not sure whether Malaysia has done a randomized controlled trial. I don't think so, right?
So there's another question for you, Dr. Tan. Although 17-OHP is not showing evidence of benefit, it's being used widely. What's your opinion on that?
So my practice is quite driven on data, and when the data showed initially that in singletons it worked, I started using it. And I was quite disappointed when the prolonged study came out to show that it doesn't work. And I'm quite quick to switch back. And I think, unfortunately, if we want to practice evidence-based medicine, we can't continue doing what we like to do all this time, because otherwise we will never learn, because some of these things are taught to us by our teachers 20 years ago, 30 years ago. And unfortunately, they didn't have the benefit of this randomized controlled trials to guide their practice. Now that we have, I think we should aim to practice with evidence, so that it's okay if we are wrong once, but we don't want to be wrong all the time.
So if we can take one last question. We have 1 minute to complete this session. The questions are just pouring in now. Patient with history of 1 preterm birth with normal cervical length, can we give vaginal progesterone? To Dr. Tan.
For singletons, there's some studies to show that it works. For twins, because we got nothing else to use, I would use it as well and then monitor the cervical length.
So thanks to all the wonderful speakers and the chairpersons of this session. I think 3:55 dot, we have come to the end of this first session. Thank you everyone for this.
Thank you, Meenakshi, for the wonderful comparing. My young robotic surgeon from Apollo. Thank you so much. And of course, our own EC member too. Thank you, Dr. Tony Tan. My profuse thanks to you. And thanks for joining. Of course, you are there in the panel too in the next session. Thanks. And thank you, Dr. Vivek. And immediately nodding yes for the invitation. Of course, our own Dr. Sudarshan Suresh and Dr. Shobna Mahadevan. Thanks a lot. And my nice chairpersons who took the job so well, Dr. Jayashree Gajraj, Dr. Parniappan, Dr. Rajpriya, all of you. Thank you very much. And we move on to the next session.
Thank you, ma'am.
Thank you, ma'am. I call upon the next coordinator, Dr. Priya, to take over session 2.
Good evening, all. I'm here to coordinate this session 2, which is a panel discussion. Albert Einstein quotes, "Intellectual growth should commence at birth and cease only at death." It was indeed an intellectual feat for all of us for the past few hours. It has quenched our thirst with certain regards to multiple pregnancy. The next in this workshop itinerary is panel discussion, which is moderated by Dr. Umar Ram. Dr. Umar Ram is the director. Dr. Umar Ram, can you please
introduce the chairpersons?
Chairpersons, we have Dr. Jaya, she's coming. Dr. Umar Ram, she's a director and consultant OBGYN Sitapati Clinic and Hospital and EV Kalyani Medical Center. This enterprising person is a chairperson in RCOG South India, IRC South India. She has contributed chapters, edited books, and publication and has publications in GDM and multiple pregnancy. She has tremendous interest and sharpened her skills in fetal medicine, fetal growth, multiple pregnancy, fetoscopy, and GDM. I could not resist myself in introducing her as a person who believes in be a different and make the difference. It's my privilege to introduce Dr. Umar Ram as a moderator for this panel discussion. Our chairpersons are Dr. Jaya Vijayaraghavan and Dr. Kundavi Shankar. Dr. Jaya Vijayaraghavan, it gives me immense pleasure in introducing to you all a beacon of light, professor and senior consultant in Sri Ramchandra Medical College. She's an experienced teacher and guide who has many researches and projects in her kitty. She has many publications in national and international journals and is starting a certificate course in obstetric medicine in 2021. I'm feeling very proud and honored to call in welcoming Dr. Jaya Vijayaraghavan as a chairperson for this panel discussion. Dr. Kundavi Shankar, this versatile personality, Dr. Kundavi Shankar, is HOD. Yes, Dr. Kundavi is an HOD and a consultant in IRM Chennai. She's a pioneer in reproductive medicine and laparoscopic surgery. She has many social awareness facets as a chairman in anti-sexual harassment committee. She's an honorary treasurer in Trapisar and ex-committee member in Fertility Preservation Society. She has conducted many conferences and the list is endless. I indeed take great pleasure in introducing Dr. Kundavi. She's a chairperson for this panel discussion. Our panelists are the eminent panelists are Dr. Suresh, Dr. Dhanalakshmi, Dr. Tony Tan, and Dr. Subham, who are going to enrich us in this session with their valuable inputs and enthrall us in the ocean of knowledge. I now welcome Dr. Jaya Vijayaraghavan. Madam, can you please introduce Dr. Suresh and Dr. Dhanalakshmi, our panelists?
Thank you, Dr. Akhila. It is indeed my proud privilege. Can you all hear me?
Yes, madam.
It is indeed my proud privilege to introduce Dr. Suresh, who does not require any introduction. He's an international figure, but however, he has its roots in Chennai as the director of Mediscan and as an honorary secretary at VHS. He's a fetal medicine specialist, as we all know, for almost 4 decades and has been conferred the FRCOG by the Royal College London in 2010. His main interest is prenatal diagnosis and fetal therapy, and he has worked in close contact with the central government and the Tamil Nadu government for training doctors for reduction in birth defects. And he has almost trained 4,000 doctors in India and worldwide. And to make a special mention is that he has established a specialized twin unit with facilities for fetoscopy and laser surgery for monochorionic twins, and he would be the most suited for this panel. Our next panelist is Dr. M.G. Dhanalakshmi, who is my close friend and my colleague at Srihar. She's a versatile teacher and a very enthusiastic teacher, I would say. And she has held many committees at Srihar as the UG curriculum committee, and she has taken excessive interest in teaching and training the undergraduates and postgraduates. She has conducted several seminars, webinars, revision courses, both at Srihar and at OGSSI. And she plays a very important role in OGSSI as an honorary joint secretary, and also enthusiastically does all the job given to her. Her interest is medical education, high-risk obstetrics, and endoscopy. I thank the organizers for giving me this opportunity to chair this important session of multiple pregnancy.
May I request Dr. Kundavi Shankar to introduce Dr. Tony Tan and Dr. Subha Karthikeyan, our next panelist.
Thanks, Akila and OGSSI, for this opportunity. I invite Dr. Tony Tan, the director who's been already introduced, but I think again, the director of Tony Women and Fetal Clinic at Mount Alvernia Hospital. He's the president of the OGSSI Society of Singapore 2013 to 14, and is the chairman maternal fetal medicine and the consultant medical director of and the consultant of Alvernia Medical Screening Center and KK Women and Children Hospital. And I invite Dr. Subha Karthikeyan. Next slide. He's a neonatal, she's working with us, who's heading the neonatal department of MMM and neonatal restoration program instructor as well, and the professional associations of membership of National Neonatal Forum, and is a life member and American Academy of Pediatrics. Another small thing is like she's very baby friendly and mothers friendly. Over to Dr. Subha and Dr. Tan.
Now, over to you, Mara, madam. You can start the session.
Thank you very much, Akila. Akila is a very dynamic member of the executive committee. She is a family welfare officer with the Corporation of Chennai, very committed to doing care for those who are socially underprivileged. And thank you for anchoring this session for us. And I hope in the next hour to discuss some aspects in terms of practical management when it comes to twin pregnancy, doing some case-based discussions. And I have a team which I'm sure will do a fantastic job, because when we are dealing with twins, we do need to have a team which will involve the obstetrician, the fetal medicine specialist, and a neonatologist. So we'll go through the scenarios. So this is a scenario one. You have a Mrs. Y who is been married for about 6 years. She's about 28 years old. She's a gravida 3 para 1 with 1 live child. She'd had a right ectopic pregnancy for which she had a salpingectomy. She's Rh negative. She's had her anti-Ds after the salpingectomy as well as her cesarean section. Then, because there was a 4 to 5 year attempt where they tried for 1 more pregnancy, they went for fertility treatment, ended up having an IVF, and this was the twin pregnancy that they saw. Can I have, so all of us from the first session will now know the chorionicity is quite clear. Dr. Suresh, can you just set the ball rolling by telling us if you're happy with these babies as you see them now?
Yeah. So what this scan shows is a clear dichorionic pregnancy with the crown rump length of 75 and 78. So they are concordant for. But what I see is I think her dates are also perfectly all right, because this was a embryo transfer date is what has been used for dating the pregnancy, and both are almost concordant. So I'm quite happy with this.
Okay. So Dhanlakshmi, this patient has the scan and comes back to you now, and she comes to you for a second opinion because she's been started on aspirin and low molecular weight heparin at the IVF unit. She's already on vaginal progesterone 200 milligrams twice a day. She's getting a daily injection of 100 milligrams of progesterone. She's been advised to stay at rest at home, and she's come to you because they have now told her you need a stitch. I'm not asking Tony this question right away because he's just spoken about it, but if she comes to you for a second opinion, Dr. Dhanlakshmi, How will you counsel her?
See, I know like the patients will be on multiple drugs whenever a patient is referred from IVF center to us. And regarding cervical stitch, I think I'll go with serial monitoring, because after all, they're going to come to us every 2 weeks and or at least every 4 weeks. And if the cervical length is at any time is lessening, say we started with say 3 centimeter, it is coming down to 2, then we should have a closer monitoring on them maybe every week. Or if it is absolutely at 1.5, then I would recommend. But because they had been referred for cervical cerclage, maybe I will counsel them a bit more and ask them to wait, because already they are on multiple drugs. And putting a stitch, maybe I would take a swab at that time and convince them and see if there's no infection is identified in the vaginal flora, I can wait.
And what about all the stuff she's on? This is a practical problem. She's come to you. So I just want to know, will you say you've been started on it, go ahead?
No. And generally, I taper it. It's very difficult to take off all medications at a time. Okay, so I say like 2 weeks you take this, then progesterone injection. By 20 weeks, I think most of them are off all the medications except for iron calcium. By 20 weeks, I'm able to convince them, but not at the immediate first visit when they come from infertility center to us.
Okay, Tony, does this happen to you in Singapore?
Not often.
Okay.
I don't know why she's on aspirin and heparin actually.
Okay. No, we do see a lot of IVF centers do start their patients on low molecular weight heparin, even if there is no other. I think there's a belief that it improves implantation.
Okay.
Okay, so let's say you stop her low molecular weight heparin. My only question is, would you have her on aspirin anyway because she has twins, or would you not be happy for her to have aspirin either?
I do routinely a first trimester screen for preeclampsia. So if she's high risk for preeclampsia, I would continue the aspirin. If not, I will stop.
Okay. All right. So she's going to go off everything by this point in time, only iron and calcium at 20 weeks. And this is the scan. And she comes to you back with this scan. Tony, are you happy? Are you worried?
Which one is the 10th centile?
So this is fetus A. Fetus A has the estimated fetal weight is on the 10th centile.
Okay. Yeah.
The abdominal circumference and head circumference is on the 22nd centile.
Yeah.
And fetus B, everything is everything is happy. I mean, your weight is on the 62nd centile.
Yeah.
The Dopplers are looking okay.
So B is appropriately grown. A is smallish, not below 10 centile yet. So I will watch A, but I think I'm worried that A will become small in future.
Okay. So Dr. Suresh, when would you want to see this? If you were scanning these babies, you'd want to see them back in 4 weeks as per norm, or would you want to do anything else at this point?
Yeah, at this point of time, really nothing is required because the fetus is still not, there is some discordancy, the dichorionic twin, and you've given the Dopplers there already. They are going to be of too much importance at this point. 4 weeks.
Volume is a little low.
4 weeks. I'd prefer to get back in 4 weeks' time. I don't think you need to do anything else.
So 4 weeks anyway is the standard review for dichorionic.
Yeah.
Okay, fine. So this is the 4 weeks. Can you just take us through this, please?
Yeah. So in 4 weeks, what's happened is, yes, the fetus A has become significantly smaller. There's a drop in the growth, and the umbilical artery has shown sort of absent diastolic flow, and the DV seems to be all right on both sides, and so obviously there is significant discordance between the twins, and I would call it as a growth restriction of twin A. The reflective growth restriction of twin A. in a diachronic twin.
Okay. And when do you want to see her again? Or what would you tell the referring obstetrician?
Well, I'll say, see that because it's a dichorionic twin, there is a growth restriction of one of the twins. The other is growing well. So the protocol is as for monitoring a singleton with the growth restriction. Similar protocol only we'll use. So probably I would prefer to get her back in 2 weeks' time because of the abnormal Doppler. Not that I'm going to do anything about it. I'm not going to make any significant decisions. Of course, her blood pressure needs to be checked, whether she's going to have any other issues. So I'll get her back in 2 weeks' time.
Okay. So if she came back with this report, Dr. Tony, you were a little worried and had good reason to be worried. Now, what are the issues that you would counsel this?
Right. I was muted. Yeah.
Sorry.
Okay.
Yeah.
So severe IUGR of twin A, and it's very premature. And I don't think we want to deliver A or B because it's so premature. I don't think we should inconvenience B just to try and save A. Because A's outcome, even if you deliver at 26 or 27, 28 weeks, is not good. So expectant management, but you got to tell them that with expectant management, we might see that twin A may have a stillbirth, and they would have to understand that if twin A dies in utero, that may sometimes happen, but it's not in any case something that we are going to deliver the twin pregnancies just because we want to save both A and B. Not at this early prematurity.
Okay, fair enough. But you said we will warn them.
Yeah.
Dhanlakshmi, anything different if you would want to add? Otherwise, if you would do the same thing, now they are back at this point in time. Dr. Suresh?
Yeah, so now the umbilical artery has shown reversal of flow, but if you go by the standard protocol, the ductus venosus is still showing forward flow, and the MCA is about 1.4 MCA-PI. That also is within the norm. I think is the blue one fetus A? Blue one is fetus A, correct. So the MCA-PI has gone below the 5th percentile. That means there is redistribution, obviously. And the DVPI has also gone higher. So this is a progressive growth restriction. But again, we just need to keep our, how many weeks is she now?
She's 29.
29 weeks.
28 to 29.
So this baby has gone into Doppler abnormalities. The ductus venosus is still showing forward flow. So if you go by the standard protocol, then we can give it a little bit more time. But in a dichorionic pregnancy, the normal twin always takes precedence. We do not want to deliver prematurely for the normal twin. So maximum attention has to be paid to the normal twin.
Okay. Dr. Dhanlakshmi, this is 29 weeks. Fetus A is 591 grams. Fetus B is 1.3 kilos. Both Dr. Tony and Dr. Suresh felt that's fine. There's a risk of stillbirth, but we really want to have fetus B going because we don't want to deliver fetus B and jeopardize fetus B as well. Is your thought process the same, or is there any difference? I think we've lost, have we lost Dana? Yeah, maybe. Okay. I think Dhanlakshmi's lost connection. So Tony, your opinion doesn't change at this point, does it?
No, but I think now that we are close to 30 weeks, I will want to monitor them weekly.
Okay.
Yeah, I want to monitor because I will want to monitor till twin A's, ductus venosus shows absent or reverse A wave, and then consider delivery.
Okay. So at this point, anything else you would do if you're considering delivery? Would you want to steroid or do you want to wait longer?
No steroids, because steroids only work if it's given 1 to 7 days before delivery. So until I plan to deliver, I won't give steroids.
Okay.
So Dr. Dhanlakshmi needs to be unmuted. That's what she sent a message.
Okay. Chitra, can you make sure that Dr. Dhanlakshmi is unmuted, please?
Ma'am, she needs to accept my request, ma'am. I'm just giving.
Okay.
Okay, sorry for that.
No problem, Dhanlakshmi. Are you able to speak now?
Hello?
Yeah, you're audible. Dhanlakshmi, do you want to say anything additionally? I think she's still having some audio problem.
No, I can listen.
She's got two things open.
Yeah,
both
you have
on
two
mobile and
devices, I
laptop.
think.
Yeah. Oh, yeah. I leave here. Okay. Can I have the question repeated?
Yeah, so I was asking, we have
Hello?
we have reached 29 weeks and we have one baby which is around 600 grams, one
Okay.
baby which is around 1.3 kilos. And both Dr. Tony and Dr. Suresh said that in a DCDA, we will monitor exactly like a singleton. So we want to monitor the DV a little bit more focus on the DV of the smaller baby. And we don't want to deliver because we don't want to compromise the bigger baby for the sake of the IUGR smaller baby.
It all depends on what is the NICU setup you have.
So you have your NICU setup.
Yeah.
Would you deliver this twin at 29 weeks with one being 600 grams and one being 1.3 kilos?
1.3. Okay, and I will discuss. We have what is called as a scope counseling. I will discuss with the neonatologist and Dr. Our fetal medicine consultant. We'll take a joint decision, and maybe I would counsel them to kind of say not deliver at this point of time, because I might give that disadvantage to the baby which is not at which is growing well. So it has to suffer the prematurity because of the other twin, which may not have a good survival after birth. That is the 600 grams.
Okay.
So I might pull on a little more, maybe with the ductus venosus.
Okay.
Maybe at this point, maybe my fetal medicine consultant might like to follow the smaller baby with ductus venosus.
That he has said. Yeah. Okay. So Shubha, can I bring you in here? So you have a 29 weeker and the couple is asking you 29 weeks, doc, 1.3 and 600 grams. What are the chances that this baby will do well in your unit?
29 weeks. I just want to thank you for the opportunity to be a part of this panel. And 29 weeks, 1.3, 1.4 kilos, they have good outcomes, actually. I would say even about 90 plus survival, and they do really well. But the 600 grammer for 29 weeks, significant IUGR, we can't say. As here you did point out, fetal death, neonatal severe complications, and long-term outcomes are also not great for a 600 grammer. Significant IUGR, lots of issues perinatally, neonatally, as well as long-term.
So, but even though you say 90% at 29 weeks outcome, you're talking short-term outcome, isn't it? So when you counsel them, You also talk to them about long-term impact of prematurity.
Definitely, definitely. And always the long-term outcome of prematurity also depends on the neonatal course of this child, right? Definitely, I would say survival is good at 29 weeks for a 1.4 kilo baby. But depending on the neonatal course, I will guide you or tell you on a day-to-day basis, update you on how this baby is going to perform.
I'm going to tell you
in the
it's
long
going to be only by, maybe at 29 weeks, it's going to be only by cesarean section. Given the
So
background.
we'll come. Yeah.
That is.
Yeah. So I think it's better to wait some more time so that the scar, with a scar, I want a better outcome.
But so this couple were counseled about the risk of potential loss of one baby in utero, and the fact that even if we delivered both babies, there's a good chance that the smaller baby will not survive the neonatal period. Therefore, they actually opted to wait because they felt that they'd rather have one baby which was healthy, because we gave them the reassurance that since it was a dichorionic pregnancy, the loss of one baby is not going to affect the other baby. And at 32 weeks, there was an IUFD of one twin. So now, Dr. Tony, when would you want to see her again? Because now she's a little bit apprehensive. Will this happen to the other baby as well?
So, so psychologically, we have to manage, and therefore we have to scan her more frequently. Although if her blood pressure is okay, she's got no preeclampsia, then there is whatever happened to that twin is specific to that twin. And she, as long as she doesn't have a disease that's affecting both twins, we carry on. We could do a baseline test just to show that there isn't any DIVC. We could do a full blood count, PT-PTT. And if that is okay, then I wouldn't do any further tests. I would just scan this other baby that's surviving regularly every 1 to 2 weeks, do a CTG, and aim to deliver this. Deliver the baby at about 37 to 38 weeks.
Okay. Dana, would you agree with that plan?
Not weekly. Now that's almost become a singleton, and this IUFD of a dichorionic twin is not going to affect the other twin in any way. Maybe I'd like to do a baseline coagulation profile just for safety sake, say maybe PTINR, and then maybe once in 2 weeks. But this FGR, the baby with FGR, the same pathology could be affecting the mother as well. I'm sure like mother has not developed hypertension so far. Otherwise, my decision will be based on maternal condition. This baby, I'll follow it up maybe once in 2 weeks.
Okay.
Because coming once a week will be too much for anybody.
And then would you plan delivery?
Because this IUFD of a twin of a dichorionic pregnancy is not going to affect the other. I will not go by weekly, but maybe once in 2 weeks or once in 3 weeks, as my fetal medicine department would tell me.
So when would you plan delivery?
36, 37 weeks.
Okay. So
definitely beyond 36 weeks.
Yeah. So I highlighted this case mainly because of the counseling that needs to go around a growth restriction in a dichorionic twin. Now we move on to this situation. So Dr. Suresh, this is somebody who presents, who's been referred at 26 weeks, and she has, 28 weeks as a TTTS stage 1 for opinion. So can you just walk us through this, please?
Yeah. So I presume that chorionicity was established before.
Yeah.
It's been referred as TTTS stage 1. So fetus B, the single deepest pool seems to be 16.8.
16.8.
Yeah, that's quite high. And the other is 1.6. The next thing I want to know is, what about the bladders? Fetal bladders, are they seen or
not?
Both
seen? Bladders are seen.
So both bladders are seen, and they're concordant for Dopplers. That's like a discordance. So obviously, this is a case which we will say is a case of twin-twin transfusion syndrome. But cervical length seems to be quite good from what I saw.
3.1.
3.1. So it is quite good. And since she's already 28 weeks, I will first see whether there's maternal discomfort. And if there's maternal discomfort, there may be an indication for doing amnio reduction, but there's no maternal discomfort. I would just wait and watch, because I want to buy as much gestational age as possible, especially when the Dopplers are normal and the babies are otherwise doing well.
So this is not somebody that you want to go in and do a laser on.
Oh, 200% no. It's already 28 weeks. And I wouldn't want to do any intervention on her, because already the liquor will be so full of vernix, and I won't have a good view. So I don't think I want to do that.
Okay. Any other things that we should keep?
Hello?
Yes?
Yeah. Any other things to keep in mind? See, I will look at the recipient's heart. I mean, the bigger baby's heart, to know whether there is no overload. And as long as that is all right, we will monitor her very closely. One is symptomatic from the mother, the other otherwise. Symptomatically, which is all right, 1 week later, I'll ask her to come. And then with 16.7, there is a good chance that there could be maternal discomfort, or at least she might not be able to lie down well. So then I will consider amnio reduction.
Okay, so that's what happened. She was not able to lie flat. So in about 48 hours, she got more uncomfortable, and so an amnio reduction was planned because of her gestational age and because of the fact that a procedure could set off preterm labor, and just the amnio, the polyhydramnios itself could set off labor. Steroid cover was given, and about 3.75 liters of fluid were removed. Post reduction, the SVP was 11 and 3.5. So when would you see her again?
1 week.
In a week? Sorry?
1 week.
1 week.
1 week. Okay, so she was monitored. Actually, she got admitted because she was coming from very far away. And from 29 weeks, we managed to take her to 31 plus 2, at which point the LICA started growing and going up again, 15.6 and 4.6. Babies remained concordant, and these were the weights, and she was feeling uncomfortable. So
Can go in for.
would you want to deliver her? You said you have a NICU 1.3, 1.8. Your neonatologist said, I'm happy. She said 29-weeker has a 90% take-home baby. We've reached 31.
Yeah, of course.
Neonatologist
So,
may be very happy.
Do we just do a
definitely-
section and say, here are your babies. I don't have this responsibility anymore.
Our job is to make them more happy.
Can
When you
we
give
not
a
go in
baby
for
at
a
higher
repeat
gestation,
amnio
they'll be more
reduction?
happy.
Sorry, repeat amnio reduction, Dhanalakshmi wants. Tony?
Yes, I would repeat the amnio reduction.
Okay, so that's what happened. She had a second amnio reduction, after which she got more comfortable. And we have now reached, and the babies remain fine, Dopplers remain concordant, and we have now reached 33 weeks. So now, Dana, when do you want to deliver her?
As long as the staging is remaining at 1, I think the
wait.
staging remains at, I'll wait.
Okay.
And I know there's a calculated risk of IUFT while waiting. I know we have to wait on tender hooks, but my aim would be to pull on till 34 minimum, so that the neonatal stay is minimum for the baby. So another 2.5 weeks.
1.5 weeks. Okay.
Yeah.
Okay. Tony, is there any sense, is there any number, if they ask you, what's the risk of one baby dying?
Very well, less than 5%, I guess.
Okay. And you're happy, when would you want to deliver her?
36, 37 weeks.
36 weeks. Okay.
Yeah.
All right. You have a strong heart. All right.
34 will be, 34 itself is little too much of an asking.
All right. So if we are under monitoring, and so certainly we would go as far as possible, but there is that small risk of neonatal loss, is what we're saying. So I think with stage 1 TTTS, there's a lot of uncertainty about which direction to go. But when you have late presentations, I think we have to go with conservative management and use our expertise. There's a lot of anxiety, not just for the patient, but also for us. But we have to fall back on evidence and what is safe practice and keep going forward.
Can I just comment on the steroids? Because
yes,
I
please.
wouldn't have given steroids here. And if we worry that the amnion reduction can cause premature labor, then we inhibit labor when it happens, then we give steroids. Because like now, the steroids was wasted.
Yes.
Yeah.
Yes. Okay. So while we're at that, can you also tell me, let's say she goes into labor at 34 weeks and we have steroided her at 28 weeks. Would you want to rescue or would you just leave it?
So unfortunately, it's trouble, right? Because rescue dose is good for the lungs, but not so good for the brain. Yeah. So I guess at 34 weeks, yeah, that's hard. Below 34 weeks, I'll probably give a rescue dose. But after 34 weeks, I wouldn't.
So Shubha, I want to come to you. I mean, here there is no loss. Both babies are doing well. But this dad is a special educator, and he says, I've read something about monochorionic twins having neurological problems, doc. So are you sure that at 34 weeks of the delivery is planned, my babies will be okay? How do you counsel these parents?
My first comment is to say that even at 34 weeks, steroids have a role. And there is some evidence saying after 34, we don't need steroids. Even now, there's a lot of evidence, I would say even in RCOG, regarding term steroids to prevent respiratory morbidities like TTN and things like that. So at 34 weeks, still, if it's a pregnancy like this and it's 28 weeks, the steroids was given and we're giving 6 weeks later, it does have a good amount of benefit, and it's worked in a lot of our pregnancies in our center and a lot of other centers. 34 weeks. So evidence-wise, what I saw was twin-to-twin transfusion with laser. There's a lot of evidence saying stage 1, there could be survival of one twin of about 85%, things like that. But otherwise, without laser treatments or without complications because of TTTS in the twins, what the evidence says is they don't have any significant long-term neurological impairment or gross motor like CP changes. There's a data which says that I think there's a recent systematic review from Finland or something which talked about babies which are less than 32 and less than 1,500 itself, and followed them till 5 years and found out that unless there is a problem with an MCTA twin because of TTTS and things like that, or if there is significant fetal growth restriction, otherwise they are as in par as a singleton in long-term neurological evaluation.
Okay. So I think the point about steroid is it keeps coming back again and again because it's something that has been dinned to us as a very important intervention for premature babies.
We do
so much so that we end up giving it in anticipation of prematurity, and we are not very good at predicting who is going to actually deliver prematurely. And so we need to be cautious even in multiple pregnancies. And we've seen a lot of multiples where multiple courses have been given, and there's very good data that is increased chance of CP in those babies, and therefore we should be cautious.
That's totally right. That's totally right. I agree. Not multiple courses. Second course with impending delivery, it's totally okay. It's 2 weeks. 2 weeks before the.
So we move on to scenario 3. This is a 25-year-old primate. She was referred at 27 weeks for a second opinion, and as a twin with discordant growth. Okay. So Dr. Suresh, you put the probe on her, and this is what you see. Of one fetus B, there's no cardiac activity. She doesn't have, she has, at this point, what are the things that you would check?
Who's going to answer?
You, because you have the probe on her.
Okay. So the first thing I will check is whether chorionicity has been reported before. If it's dichorionic, I'm not going to bother. And for the other fetus in monochorionic, I will do a Doppler, especially MCA Doppler. And you go back and see she's not had a scan at 12, 13 weeks and no correlative assigned. Okay, so my answer is very simple. If I'm not sure of the chorionicity, I will consider the pregnancy to be monochorionic for safety purposes. I will treat them exactly like what I would do a monochorionic. Now, having said that, this IUD must have happened some time ago. So any kind of hemodynamic disturbance should have happened at the time of demise. So right now I'll just look at the detailed neurosonogram for the baby and then look at the middle circulatory Doppler. And then we'll decide whether an MRI will be required or not.
Dhanlakshmi, she gets referred to you for her obstetric management.
27 weeks with one IUD.
Yeah. In somebody in whom chorionicity has not been clearly
established. As sir already said in his earlier lectures, where chorionicity is not established, then you'll have to take it and treat it like a monochorionic. So, and since the damage would have already occurred, so whatever we can do is to wait for, assuming that, say by the time she comes to us with the loss of fetal movements on one side at reduced relatively. So from 3 weeks from now, we can suggest a MRI for the sake of neuroanatomy of the surviving twin, and we'll have to counsel her because whatever has happened. So we'll take this twin to a acceptable gestational age and which you could have a better outcome rather than jump and do at 27 weeks anything.
So you won't deliver her now.
I'm going to wait.
You want to wait for her.
I'm going to wait.
Okay. So this was her scans that from the earlier scan, this is what it has shown. But by the time she comes to you, there's an IUD. So is there any way you can assign chorionicity now, you think? Tony?
Well, we can look for fetal anemia in the co-twin. So we can do MCA, peak systolic velocity. If the co-twin has got fetal anemia, then there's a possibility that this is a monochorionic pregnancy. The other way is you can do the SNP method of NIPT. The SNP method of NIPT actually allows you to determine zygosity. And if you show that these are dizygotic twins, then you know they are dichorionic. Then you don't have to worry about this co-twin problem.
I don't know do we have that option for us here, Dr. Suresh?
I don't think so.
Saying chorionicity now, I don't think I will lose sleep over that because making an attempt where there is no liker on the other side to going to identify the twin peaks, and if I see one placenta in the anterior wall and one placenta on the posterior wall, then I'm easy. If both of them are on the same wall, I will sit back and relax and I won't waste my time trying to assign chorionicity.
Okay. So when would you want to deliver this baby?
I'm likely to be wrong in 30-40% of the time.
Okay. So when would we want to deliver this baby?
37 plus weeks. Because this baby does not have much of provided the growth is okay going along the 50th percentile around I would like to deliver 37 weeks plus.
Okay.
Only thing is we'll have to kind of comfort the mother because having a dead baby inside next to the surviving twin is really disturbing to the mother. The psychological counseling will have to be with the mother during this time.
Sure, because that's a very common worry that they have, whether that will affect the other baby. Okay.
They think the bad blood will come into this baby.
Sorry to disturb, but if it's an MCDA, wouldn't there be an insult to the other twin? Like,
There could be, but that's what Dr. Suresh said, that if it was immediate, sorry, go ahead.
No, it can be, but we can't do anything about it. By waiting for longer, we'll get a good gestational age because we are not going to reverse the damage in any way or worsen the damage in any way.
But the longer in utero with an MCTA with another twin which is dead, will the cerebral damage be further?
No, no,
The
no.
insult will be further?
No, no. Usually the insult happens at the time when the
demise.
demise happens. The pressure changes are there. Not all of them will be like that.
Oh.
There will be a significant portion of them will have a sudden pressure change, and the effect on the brain is not uniform for all babies. Some of them will develop up to porencephalic cyst and all that.
Yeah.
They may not have anything at all. May not have anything at all. So we just have to wait and watch. That's all.
And we can't determine it by just a sonogram, right? These
Can't we do MRI, sir, as the literature suggests, after 4 weeks?
That's what he said. You can do MRI.
You can do a high resolution scan. Ultrasound, very good ultrasound can be done. Certainly an MRI can be done.
And
but
both
that's
will
after
give
30
us...
weeks. After 30 weeks.
Okay. And if they're both normal, you can get some reassurance about the neurological structural, but you can't really comment on function. Am I correct?
Definitely.
Yeah. Okay. So we move on to the fourth case. So this is a 23-year-old primate. She's O positive. She had irregular periods, was given Clomid for ovulation induction. She had a DCDA twin, BMI 21.75. I'm being very kind to both you obstetricians. She has no other medical problems, concordant growth. Now she's sitting in front of you at 35 weeks and she wants to discuss delivery. So Dana, what would you tell her?
See, I would like to deliver her by around 38 weeks. 38 weeks is the time, provided she does not get into labor on her own. Otherwise, I'll wait till 38 weeks. Most of the time, they themselves will get into labor by that time. And I'll say I will decide based on the presentation of the first twin at the time of induction or spontaneous onset of labor, whichever is earlier. So if the first twin is cephalic, definitely I might give a try, provided the first twin is not very much different in weight. The first, second twin is not.
They're concordant. She's a happy.
Okay, they're concordant. Okay. So then if the first is a twin, then first twin is a cephalic, definitely I'll give a vaginal delivery. Otherwise, non-cephalic, I'm not very comfortable doing all kind of versions. So I would suggest to her a cesarean section straight away.
So Chitra, can we run the audience poll now, please?
Yeah.
So can the audience vote for both these answers? If you have a twin pregnancy and both are cephalic, would you allow a vaginal delivery? If you have a twin where the first is cephalic and the second is breech, would you allow a vaginal delivery? Okay, so that's 50 people only who voted, but 100% of them said that they will allow it if both are cephalic. 25% said they wouldn't if the second was breech. Okay, so Tony, you agree 38 weeks?
Yes, 38 weeks.
And you're happy if the second is a breech as well?
Yes.
Okay. So she was scheduled for induction of labor 38 weeks. She came in spontaneous labor at 37 plus 3. Both were cephalic. She was contracting 2 in 10. Cervix was 1 centimeter long, 1 to 2 centimeters dilated, bag of membranes forming. So what would you want to do with her?
I will first make sure that everybody is alert that there is a twin pregnancy which is about to deliver. Take blood for cross-matching, grouping and cross-matching, and make sure that 2 pediatricians, 2 neonatologists are available for resuscitation. Okay. And I'll also keep the emergency theater.
So you want to do anything now, or you want her to just
No, I want her to go in for spontaneous progression. Spontaneous, till 4 centimeter, I wouldn't touch her.
Okay. So 3 hours later, she requests pain relief. She's contracting 3 in 10, 20 to 25 seconds. She's 0.5 centimeters long, 3 centimeters dilated. Head is at -1. Membranes are present. She's counseled and she takes an epidural. At this point, either of you want to do anything?
I will let the membranes be in situ as long as it's good.
Okay. Tony, if you...
Yeah, I'll do that. I'll advise her to do an epidural as well.
Yeah, so, and what about monitoring the fetus? Would you have her on a CTG all the time?
Yes, continuous monitoring.
Okay. And a frequency of review? How often, now she's taken pain relief, when will you examine her again?
She's 3 centimeters, so she's not yet got into active labor. Maybe after when she gets good contractions, maybe 35-40 seconds, that when the frequency increases with the intensity increases, maybe 3 contractions in 10 minutes each, lasting for about 35 seconds. I like to do a PV, maybe at 2 to 4 hours.
Okay. So 4 hours later, epidural is on board, it's working. She's contracting 3 in 10, 30 seconds. She's well effaced, 3 to 4 centimeters. She spontaneously ruptured membranes 2 hours ago. It's clear like her. But she's so at this, would you be happy to use oxytocin in twins, or do you want to wait? Tony, and what about partogram?
I will use oxytocin in twins. I think no problems with oxytocin in twins. And the partogram, I think, is no different between twins and singleton, especially for the latent phase. I think the Americans now say latent phase is up to 5-6 centimeters. So it's just a bit slow in the first 5-6 centimeters. And beyond 5-6 centimeters, then it fast again.
Okay.
She got into 4 centimeter on her own. So wait, I think so you must allow the twins to adjust and come in alignment with the uterine axis and come out. So I would think about oxytocin, not think about it.
Okay. So 4 hours later, she was about 5 to 6 centimeters and head was at -1. And so she was started on oxytocin. CTG stayed reactive. So in 4 hours, she's gone from 3 to 4 to 5 to 6. So should we persist with this labor or should we bail out?
Persist, because still latent phase, yeah.
Okay. Dhanlakshmi?
I will persist. I will just wait for some more time.
Okay. So the couple also were quite happy to wait because they were very keen on a vaginal delivery.
She's an epidural, so you'll have to give that extra 1 hour.
Yeah. She became fully dilated in 3 hours' time and spontaneously delivered 2.6 kilo baby. Post-delivery, when you assess for the second of twin, the placenting part is high, the bag of membranes is tense, you're not sure. So you know.
This is a typical scenario what we get.
Yeah. So at this point, what would you do?
If scan machine was not there, probably I would have gone and taken off my gloves, went and assessed the the presentation of the second twin by abdominal examination, because PV wouldn't give me any much better clue. So I can do a controlled ARM. I can do a controlled ARM now.
Okay, Tony?
Yeah, the variable cells, are they very bad or they are just mild ones?
Yeah, there are a few variables. They're going down to about 100, between 90 and 100, but there's a quick return.
Okay, all right. So, and the contractions are how frequent?
The contractions are about 3 in 10, okay, but about 20 seconds each.
Yeah. And the vagina examination now is still os full and the head is down?
Os full, there's a tense membrane. It is a head, but it's a little high.
Okay. Yeah. So if it's
scan machine confirms that it is cephalic.
Yeah. Or if I think I can rupture the membranes without if the head is not too high, I will rupture the membranes.
Okay. All right. And then allow a vaginal delivery. Anybody, would you want to do an external cephalic version? I mean, would you want to vert it to a breech and then pull the baby out? Is that faster?
No.
Yeah. No, sometimes when the second is a breech, you can actually do something to help the delivery.
Yes,
The
yes, that's
second
true.
is a
That's true.
head. You just have to wait for it to
Wait.
drop into the pelvis and do a controlled air. Okay, so your what are the chances, or what if for some reason this baby does not come through, or the head does not come through? Are there any reasons or any tips
Maybe
for the
slightly
second
bigger, slightly
management?
bigger. Where the second baby could have been bigger, and
how much longer will you wait? Let's say you do ruptured membranes, the head is started to come down. How long will you wait for that baby's
because
to
she's on
come through?
epidural, 2 hours, maybe maximum 2 hours.
Provided the CTG is okay.
Exactly.
Yeah.
Yeah. And it depends on the CTG. So when we do delayed interval delivery, we can even wait for weeks, you know. So actually, if the CTG is okay, there's no real
rush.
Rush. Yeah.
Okay. The clock's not ticking if the CTG is okay.
Yes.
Okay. All right. So postpartum concerns. Shubha, this woman wants to exclusively breastfeed. Very often, mothers of twins are advised to formula feed. I just want your thoughts on that.
Yeah, she can. It's possible. It happens. If they are motivated, because it's a lot of effort, because with one baby, these mothers are unhappy about lack of night sleep. But if she's a really motivated mother, a lot of our preterm mothers have gone home breastfeeding. The only thing is they can't do breastfeeding for both babies at the same time, because these dual footballs don't work. But we advise them to pump so that one child can be fed at a time, when the other child is screaming. But they can definitely do it. It's not at all impossible.
Okay. All right. Thank you.
Welcome to the webinar. You have been.
Okay. So, no, I just thought we'll do a little bit of focus on intrapartum, because a lot of times, especially for the juniors, there is anxiety and concern when you have a twin labor. If we have a little bit more time, I think we do have about 7 minutes. I wanted to go to scenario 3 again and do version 2. Dr. Suresh, this is it is known that she's an MCDA twin. She's referred to you at 27 weeks, and this is what you're seeing.
Okay. Okay, looks like what about the Leica?
So there is Leica around fetus B.
Okay. And there's no polyhydramnios.
No, there's no polyhydramnios.
Okay, so this is obviously a selective growth restriction.
5 minutes.
Selective growth restriction with reverse diastolic flow in the umbilical artery, and looks like the ductus venosus also looks quite abnormal. So this is a type 2 selective growth restriction, because we are seeing continuous reversal of flow. And fetus A, is that the larger twin or the smaller twin? Fetus A is the larger twin.
Fetus A is the larger twin.
And that seems to be having some cardiomegaly and tricuspid regurgitation.
Yeah.
Oh, okay. Now, Dr. Sinath has ascites present, pericardial effusion, cardiomegaly, pulmonary stenosis, cerebral redistribution. Okay. So here there is oligo and there is normal, and but this fetus is having ascites, pericardial effusion, cardiomegaly, pulmonary stenosis. So obviously there's a volume overload happening here. And the middle cerebral artery 1.04 mom and 1.46 mom. Well, on the borderline of TAPS, it's on the borderline of TAPS, but certainly fetus A looks quite cardiac is overloaded, and fetus B with the growth restriction has got persistent reversal diastolic flow. So we are facing a bad situation for both.
Yeah, that's why they've been referred to you.
Yeah. So for me, you said she's 27 weeks, right?
Yeah. She's referred at 27 weeks and referred as TTTS.
Yeah. So if the liker is not more, see, my whole problem is there is no polyhydramnios, but there is cardiac failure. So when there is cardiac failure and polyhydramnios,
your volume is fading.
Volume is, are you able to hear me?
Yeah, better now.
This is a very difficult situation. If the discordance is 600 grams and 287 grams, almost more than 50% discordance. So the best scenario for me is to, we are cross 27 weeks. It's a dilemma, but we still go and do a selective fetal reduction for the smaller twin, in the hope that this baby will not have a volume overload and this will reverse over a period of time.
Okay. So even though this is the baby which has ascites and pericardial effusion and cardiomegaly.
Yeah, because see, the other baby, the smaller baby, first of all, the size is very small. Secondly, it has got, the Dopplers are abnormal. And that means this is a selective growth restriction with type 2. So it is the smaller baby always we target to do whatever to do. Now, there's a component, there should be a component of volume overload for the bigger baby.
Okay.
So that's the best we can do, and hope that things will revert.
So this is a situation where, you know, she needs to be counseled adequately about the possible risks of both babies and a possible poor prognosis, even if there is a procedure that is done. And even though she's 27 weeks, delivery is not an option because neither baby is going to do well.
No, delivery is not an option. The best scenario, maybe we should ask Tony what is that.
Can we not wait till the fetus, wait for some more time?
Because it's a monochorionic, because it's a monochorionic pregnancy with a selective growth restriction with Doppler changes, there is a good chance that one baby will die in utero while we wait. So
in this scenario, I would offer her cord occlusion of twin B.
Yes, cord occlusion or radiofrequency
ablation. So, I mean, the reason I put this up is because sometimes these cases are quite complicated. And it's important that people who know how to manage it. And unfortunate, I mean, and human nature is such that even when they get a opinion from the experts who do the procedure, often they come back to the obstetrician to ask us, is that acceptable? Is that advice what we need to do? And sometimes the obstetrician may say, actually, you can just terminate this entire pregnancy. And I think that's not appropriate advice without walking through the options. And if that's what the couple want, that's a different issue. The couple may say, we don't want to do anything because this whole thing is complicated and we'll just wait for nature to take its course. But otherwise, there needs to be a lot of communication between the fetal medicine team and the obstetrician and potentially subsequently the neonatologist who's going to deliver. And in these complicated babies, it's often teamwork that works. So this patient actually opted to have a radiofrequency ablation and the other babies did improve. So in this kind of a situation where we have done a procedure, when would you time delivery?
And a procedure 32 to 34 weeks.
No, at 27 weeks.
At 27 weeks, she has had a RFA.
Radiofrequency ablation, yes.
That means they have converted the placenta into dichorionic, kind of.
No. They've done a cord occlusion.
Cord occlusion only.
Radiofrequency ablation has been done. So there's only one baby that's alive and growing now.
Okay. We can give it maximum time.
To deliver.
The baby should improve. Hopefully it should improve. The surviving baby should improve over a period of time. Maybe every 2 weeks you can follow the baby and take it At least my immediate target would be to take it up to 34 weeks.
Tony?
Yeah. So if baby improves, I would aim for 36, 37 weeks. Yeah.
Okay.
I guess there's no.
Asma, do you want to make any comment? Welcome.
Yes, I mean, I joined, but I was listening. I didn't want to interfere.
Yeah.
Interrupt, but I guess there's no indication to deliver early.
Yes.
But I think it's important to do an MRI for this baby.
For the surviving baby.
Yeah, I mean, I guess I assume if the woman agreed to have selective termination of the smaller baby, I suspect she would.
So you routinely get an MRI on the other baby after procedure?
Well, because there is a risk of I mean, even not necessarily related to the procedure, even the fact that this was a complicated monochorionic twin pregnancy with selective fetal constriction and intertwin transfusion. I mean, this baby was hydropic because of the overload of this twin, and therefore and had pulmonary stenosis as well. So I think you just want to confirm that the brain is normal. The brain abnormality could be related to two things. It could be actually related to the complicated monochorionic twin pregnancy itself, even before you do the procedure, but also the procedure-related risk, which is known to be associated with a degree of neurological abnormality.
But in the UK, you do an MRI because if you pick up any brain damage, you can do a late trimester termination. But I don't think that's allowed in India or in Singapore, actually. So therefore, it becomes academic then.
But she had already selected termination at 27 weeks. I mean, that's exactly the same. In fact, you could argue that the one that she had. I mean, in fact, there's someone on one of the delegates asking about this. Is it legally permitted to go for termination at this stage, which is 27 weeks? I think it's the same principle.
Would it come under the broad terminology called as termination?
It is termination.
It is termination, but
would it be under the
because no, it is selective termination, but I think we don't have any clear directive to avoid that says we cannot do selective termination if there is a fetus which is in trouble. The PNDT Act essentially talks only about termination of the entire pregnancy. And I think that is why one is able to do these procedures slightly later on in pregnancy when it is indicated in such situations. Dr. Suresh, did you want to say something?
No, I think I'm quite okay with what the thing is as far as MRI is concerned.
Yeah.
It does give information for counseling the patient, but nothing much can be done in our scenario.
But I think we also have a limitation in the availability and access to that fetal MRI because there are only a couple of units that actually do it. So I think that is another limiting factor where we probably should get more expertise coming in, even as other aspects of fetal therapy are being more and more available to patients. Okay, so with that, I think I'll sum up and say thank you very much to all the panelists and emphasizing that we need to have teams that work together to get the best outcomes. And the evidence in this area is constantly changing, and we need to keep abreast so that we can continue to give our best to these women. Thank you very much.
Thank you. Thank you, Ma.
Thank you, Madam, for the interesting and lively case discussions. Madam has practically discussed the practical approaches of various stages in twin pregnancy, right from early pregnancy, intrauterine death, and delivery and postpartum. Thank you very much, Madam. I hand over to the next coordinator, Dr. Priya.
Akhila, wait. Let the chairpersons do some comments.
Yes, ma'am.
Dr. Jaya and Dr. Kundavi.
Thanks for the great panel by Dr. Uma and with an excellent panelist with a great take-home message. I think it was a very clear message and a beautiful case scenarios. Thank you, Dr. Uma and the panelists. and probably a good message to the ART specialist like me. Thank you.
Thank you. Jaya? Jaya, madam? Dr. Jaya wanting to say anything?
Dr. Jaya, madam.
Okay, so thank you, Akhila, for moderating that. Welcome, Dr. Asma.
Hello.
Hi. Yeah. Thank you, Uma, for that wonderful panel with beautiful scenarios. Thank you, Dr. Suresh, Dr. Dhanalakshmi, and of course, Tony and Dr. Shubha. Thank you, Shubha. Yeah.
Hello.
Thanks a lot. And I think we move on to the next session. Yes. So please, Akhila, please introduce the next coordinator.
The next coordinator, I call upon Dr. Priya to take over to the next session. Over to you, Priya.
Yeah, Priya is a consultant with Mehta Hospitals and a very newly joined executive committee member in OGSSI, but very active and I would say very obedient too. Welcome, Priya, to moderate this session.
Thank you, madam. Thank you. So, I welcome all the delegates to the last but not the least. This is the last session for today. So I think, hope you had a very nice time. And I take great privilege to introduce Dr. Vijayalakshmi Seshadri, madam, our beloved president. Madam is a senior consultant in Sundara Medical Foundation. She's an executive member in the Tamil Nadu OGSSI and a constitutional committee member in the ISOPAR, a breast committee member in FOXI, quiz committee member, IMS chairperson, research committee member. Madam has been an active participant. Madam told us not to give a long introduction, but sorry, madam, we'll just go by. And I would like to introduce a co-chairperson, Dr. Hepzibah, madam. Madam is a vast experience in obstetrics and fetal medicine. She conducts a fellowship course in fetal medicine in Savita Medical College. Madam has got many awards, including the CS Dawn Prize, A.L. Mudaliar Award, Lifetime Achievement Award from the MGR University, APJ Abdul Kalam Award, a TMMC Award for Medical Teaching, Academic Excellence Award. She has developed apps for midlife and beyond and gestosis. Madam has written many textbooks. She has presented papers in many national and international conferences. So over to the chairpersons, madam.
Thank you, Priya. So we move on to a very expected and very anticipated talk from Dr. Asma Khalil. Dr. Asma is the professor of the obstetrics and fetal medicine at the St. George's Hospital, University of London. She is also the obstetric lead of the National Maternity and Perinatal Audits. She is a lead for the twins and multiple pregnancy services and the reproductive health research group at the St. George's Hospital. So we thought she would be the right person to discuss today on very important topics. And she's also the trustee of the International Society of Obstetricians, the ultrasound in obstetrics and gynecology. She is very passionate about innovations and has invented a digital innovation called Hampton for monitoring domestic monitoring of the blood pressure. So she would be now deliberating on fetal anomalies in twins. Over to Dr. Asma.
Hello, everyone. It's my pleasure to give this talk on the fetal anomalies in twins. It's important that we know that anomalies tend to be more common in twins, particularly obviously monochorionic twins, more common than dichorionic twins. And also that the fact that most of the times when the twin pregnancy is affected by abnormalities is affecting only one twin in more than 80% of the cases. How good is the first trimester ultrasound scan in detecting abnormalities? We published this paper years ago, and the detection is about 30% or under 30%. We only detect really only a third of abnormalities in twins in the first trimester. And the risk factors is monochorionicity, so associated with high risk of structural abnormalities, as well as crown rumplings, discordance, or even discordance in the nuchal translucency. Interestingly, that the same detection rate or very similar detection rate of abnormalities in twins in the first trimester was also reported in this paper by the Fetal Medicine Foundation or King's College. So again, 27% in dichroic twins. In monochorionic twins was 50%, but actually included also monochorionicity-related complications such as trap or twin reverse atrial perfusion sequence and conjoined twins, and therefore you have a higher percentage, which is 50%. So what's a common scenario is this pregnancy was referred spontaneous MCGA twin pregnancy with crown lumpiness discordance with twin 2. The CRL is less than 10%, and you can see that on the charts is twin 1 is twin 2 small, and twin 2 also has multiple abnormalities. As you can see in the next ultrasound, so hydrop, exomphalus, holoprosencephaly, bilateral blue effusion, generalized skin edema. And you can see here, so this is one of the twins is normal, and the other one is hydropic. And you see here, so in this clip, this one is very hydropic with exomphalus and multiple abnormalities, while twin 1 is completely normal. So in this case, we offered laser, intrafetal laser, quite simple technique, ultrasound guided, to stop the blood flow, umbilical blood flow in the abnormal twin. And the pregnancy continued, and this woman had a baby girl at 37 weeks, average size, and had a normal cranial ultrasound scan. And therefore, I mentioned to you the detection rate is just under 30%, which is interestingly, it's very similar to the detection rate of abnormalities in singleton pregnancy in the first trimester. So yes, scanning twins is more challenging and we need more time, but actually you could potentially achieve the same detection rate as what you do in singleton pregnancies. The commonest abnormalities that affect the twins are the heart abnormalities and the one that affect the central nervous system, so particularly the brain and neural tube defect. And monochorionic twins particularly have higher risk of midline anomalies. And probably the most extreme form of midline anomalies would be the conjoined twins, which often they tend to be joined in the midline. There are also other group of abnormalities that we come across in twin pregnancies, which are malformation that resulting from a vascular event, often in the form of hypotension or ischemia. So these abnormalities, examples is brain abnormalities like periventricular leukomalacia, so secondary to ischemia, ventriculomegaly, cerebral atrophy, or other organs like bowel atresia, renal dysplasia, or limb amputation. And therefore, in the follow-up of particularly complicated monochorionic twin pregnancies, we need to look for these abnormalities. So there's another case. This was a second pregnancy, so again, spontaneous monochorionic diamniotic twin. The 12-week scan was normal with low risk of abnormalities. The 16 weeks, there was signs of twin-to-twin transfusion syndrome in the form of amniotic fluid discordance and size discordance. Twin 1 had increased fluid polyhydramnios. You can see here it was distended bladder, and this twin had suspected congenital heart defect. So that was the recipient. And when they had an echo on the same day, there was pulmonary stenosis, but which also associated with TTGS. But also there was noted to be sinus bradycardia, and we saw that this baby might die. But a few days later, at 17 weeks, there was progression of the TTGS, and we did a laser surgery. After the laser, there was rupture of membranes, and we tend to manage these cases expectantly because the prognosis is not the same as spontaneous rupture of membrane, which a lot of it is related to infection. So we do the full ultrasound scan. The TTGS resolved, so there was no longer polyhydramnios. But what we see here is this twin, which is twin 1, the twin 1, the ex-recipient, the one that have pulmonary stenosis, while twin 2, this twin had hyperextended neck, very abnormal position, and that was the ex-donor, and the brain was also very abnormal. And we confirmed that on the MRI, 22 weeks. And you can see here, so this is the ex-recipient, the one that have the heart abnormality, with normal brain, while actually the ex-donor was a very abnormal position in form of hyperextended neck, very abnormal brain in the form of hypoxic ischemic brain injury with bilateral cerebral malformation. So almost this baby had a stroke. You can see the brain here is very abnormal. Of course, the parents were counseled about this very poor prognosis of this twin and offered the option of selective termination. And that's can be done later in pregnancy, so in the third trimester, to minimize the risk of prematurity for the normal twin, particularly this twin had pulmonary stenosis and would require cardiac surgery. And therefore, we would really prefer to avoid the risk of preterm birth for this particular twin. The parents asked, of course, which twin to survive. If the brain is so abnormal, one option is expected management, and this baby might actually die after birth. However, we felt that this is there is a high chance that the baby could survive, and we agreed that we were going to repeat the MRI, particularly obviously looking at the brainstem. So twin 1 continued with growing normally with normal amniotic fluid, normal Doppler, while twin 2, the one that has very abnormal position and abnormal brain, developed polyhydramnios. The stomach was invisible because obviously baby is not swallowing. Second, it's a neurological insult. And because the polyhydramnios, we had to have contingency plan if the woman goes into preterm birth. Was given course of steroids, and we repeated the MRI at 31 weeks. And twin 1 have a normal brain, while twin 2, the one that have abnormal brain and marked very hyperextended neck. This baby had extensive malformation, so bilateral cortical malformation. However, interestingly, the brainstem and the cerebellum have been normal, so there is a chance that this baby could survive. At 32 weeks, polyhydramnios becomes severe and the mother is symptomatic. We were monitoring her with the cervical lens, as you can see here. She opted for selective cord occlusion, which was quite straightforward because this was the one that had polyhydramnios, and you can see the umbilical cord insertion is there. We give a repeat course of steroids because of the risk of prematurity. A week later, she goes into preterm labor and have an emergency C-section, and twin 1 is doing well, the one that had the pulmonary stenosis and had the cardiac surgery. And the other thing that we need to be aware of is that pregnancies or monochorionic twin pregnancies that have twin-to-twin transfusion syndrome have increased risk of right ventricular outflow tract obstruction and the form of pulmonary stenosis, pulmonary atresia, which affects 10% of the recipients. And the risk factors will be abnormal ductus venosus or pericardial effusion, but early onset TTTS are also possible predictors of the right ventricular outflow tract obstruction. And therefore, the follow-up of these cases, we need to look at the heart. Another case, again, that was sent on Friday, so 28 years old, first pregnancy, spontaneous monochorionic diammeter twin, was having a local follow-up. And we noted that there was a ventricular disproportion, but that was felt that maybe that's part of the TTTS. So at 24 weeks, plus had the TTTS and was referred for laser surgery. That was done on Friday evening, and on Saturday morning, there was demise of the ex-donor or the former donor, and the recipient had normal Dopplers, including normal middle cerebral frosty, there was no signs of anemia. And the surviving twin had a ventricular disproportion. If you see here, the left ventricle is actually smaller than the right ventricle, which is not consistent with right ventricular outflow tract obstruction, which you'd expect the right ventricle to be the one that's smaller. We sent amniotic fluid for array CCH and came back as William-Browen microdeletion syndrome, which can be associated with supravalvular aortic stenosis. If we remember, there is a guideline that we wrote back in 2016. We did recommend that we should, the detailed anomaly scan in twins, need obviously to look for the detailed assessment, particularly obviously the heart, because of the increased risk of heart abnormalities, particularly in monochorionic twin. And if you have a discordant anomaly in a monochorionic or monozygotic twin pregnancy, you should consider doing double amniocentesis in order to not miss the diagnosis of heterokaryotype monozygotic twin pregnancy. When you manage these pregnancies, there are three options: either expectant management, or selective termination of the affected twin, or termination of the entire pregnancy. And therefore, the counseling, we need to discuss about the risk of the mice, particularly of the affected twin, and the potential consequences of the normal twin, the risk of miscarriage, and the risk of preterm birth, particularly following invasive procedure. When we the thing that we need to take into account during this counseling is the chronicity, because the management in dichorionic is different from monochorionic twin pregnancy. The amnionicity as well, because if it's a monoamniotic twin pregnancy and you do cord occlusion, you need to consider actually doing cutting the umbilical cord or transection of the umbilical cord in order to avoid the risk of cord entanglement or cord accidents. The type of anomaly, whether it's a lethal abnormality or not. Because if it's a lethal abnormality in a dichorionic twin pregnancy, expectant management is a reasonable option. The gestational age assessment, we try to avoid intervention in the second trimester in view of the risk of preterm birth or miscarriage. The parents' wishes, of course, and of course the law where you work. And therefore the management, as I said, depends on the chronicity and the type of abnormality. So in dichorionic twin with one twin have trisomy 21 is different from trisomy 18, because trisomy 18 is a lethal condition, and therefore you expect the management is a reasonable option. So another case which really was quite challenging because it raised a number of challenging problems. So this was a lady who was a surrogate mother who was we first saw at 31 weeks plus 6 days during COVID with restricted travel plans. The first twin was normal, but the abdominal circumference was less than 10 centile. The fetal Dopplers were completely normal, and the baby was structurally normal. The second twin had a number of abnormalities. So the second twin had short, long bones, the femur and humerus. It had polyhydramnios. The Dopplers were normal, but had a number of abnormalities, including a large anterior abdominal wall defect. Both the liver and the bowel were seen floating in amniotic fluid. Some of the fetal parts were seen actually outside the amniotic sac of this twin. There was kyphoscoliosis, there was spina bifida, there is talibus, polyhydramnios, short umbilical cord. And you can see that in these clips. And of course, these abnormalities highlight the risk that there could be amniotic rupture sequence or body stalk abnormality. So you see here, we run it again, that was, you can see the abdominal wall defects, and there's a bowel and the liver was outside. And here you see that it's actually some of the fetal parts were outside the amniotic sac. There's a spina bifida and kyphoscoliosis in this twin with increased amniotic fluid or the polyhydramnios. And you see the very short umbilical cord, which again can trigger the alarm bells that it could be body stalk anomaly or amniotic rupture sequence. And this was talibus in this baby. So of course, the challenging aspect of this pregnancy is the fact that it's a surrogate mother, it's a late diagnosis. Should we offer selective termination? This baby is very likely to die, then you need the mortality is extremely high. And also her chance or her risk of preterm birth. So literally a week later, she had rupture of membrane and went into labor, and twin one had spontaneous breech vaginal delivery. That was the normal twin, and that was fine, the baby was fine. While twin two, the one that had the amniotic rupture sequence, was a very short umbilical cord. There was a delayed delivery, and ended up by having a cesarean section and died shortly afterwards. And this is the twin that had abnormality, which is the one we saw in the scan. So large anterior abdominal wall defect, the liver, the bowel outside. You can see the kyphoscoliosis and the spina as a spinal defect. You could see also there is the talibus. And the reason, I guess, why she needs the section potentially is because of the very short umbilical cord. If we have a lethal abnormality or any any twin pregnancy complicated with discord anomaly, really think of referring this one to a fetal medicine specialist, particularly if they have expertise in management of twin pregnancies. And as I mentioned earlier, if you have a lesion abnormality in dichorionic twins, conservative management is a reasonable option. One in monochorionic twin pregnancy, where the demise of the abnormal twin have consequences on the normal twin, and therefore you should consider the option of selective termination. How do you do it? Well, it depends on the chorionicity. So in dichorionic or trichorionic multiple pregnancies, in this case, we do ultrasound-guided transabdominal injection, either intracardiac or intrafunicular inside the umbilical cord, injection of KCL or lignocaine if you don't have access to KCL. And we ideally in the first trimester, in view of the fact that the lower risk of miscarriage or preterm birth. However, if you made the diagnosis in the second trimester for the first time, we should consider, or at least where you work, we also consider the option of late selective termination in the third trimester to reduce the risk of prematurity of the normal twin. And monochorionic twin pregnancy is more complicated because of the risk that the KCL can cross the anastomosis into the normal twin, and therefore we need to do intrafetal or occlusive methods like cord occlusion or intrafetal coagulation using laser or radiofrequency ablation. And generally speaking, the survival is 80%, but there is risk of premature rupture of membrane or preterm birth and a small risk of adverse neurological sequelae. The techniques that we use for selective termination in a monochorionic twin pregnancy includes the option of cord occlusion. And cord occlusion, as I mentioned, the survival is about 80%. There's a number of techniques over the years, but the commonest is the bipolar cord coagulation. The operative sleeve is about 3.8 millimeter. And in monoamniotic twins, we also need to do cord transaction. We need to be aware of the risks of the complication in the form of the co-twin intrauterine demise, which is reported in maybe after 15 to 20%. Obviously, the risk of rupture of membrane and the risk of neurological sequelae. The potential problems with the cord occlusion is the fact that if you have an hydramnios, for example, if you have short umbilical cord, but also the port is larger compared to the smaller size of radiofrequency ablation or intrafetal laser. And you can see here the difference in size, and which means that the radiofrequency ablation and the intrafetal laser can be performed earlier in pregnancy. The interstitial laser, very simple technique, using CVS needle, ultrasound guided, and we use we pass a 400 or 600 micron laser fiber, pass down the CVS needle, and we photocoagulate the blood vessels in the fetal pelvis or the target umbilical vessels. And I think the main issue of the radiofrequency ablation and the intrafetal interstitial laser is the fact that it's less controlled compared to cord occlusion. However, generally speaking, the choice of technique depends on expertise and available equipment. Each option has its pros and cons, and it depends obviously on what's available and where is your expertise, what you used to. Selective termination or selective reduction, the majority or the risk of demise of the remaining twin, often the majority occurs in the first 2 weeks, 2 weeks after the surgery. And as I mentioned, the various options, and to some extent the survival is reasonably similar. Is the risk of preterm birth increased in twin pregnancies complicated by discordant anomaly in the absence of polyhydramnios? And the answer is no. If you see here in this study, they compared those twin pregnancies with discordant anomaly versus one that without abnormality, and you can see there's no difference in the risk of preterm birth. Another case, just to demonstrate that congenital infection can affect one twin and not the other, and in fact, both twins affected or infected, but affected differently. One of them can have severe abnormality secondary to the infection, and the other one is not. So this lady was 34 years old, had a previous uncomplicated singleton pregnancy. She was referred at 31 weeks plus 4 days with spontaneous dichorionic diameter twin pregnancy, and twin one had severe bilateral ventriculomegaly, and the walls of the ventricle were described as being echogenic and thick, and there was suspected intracranial hemorrhage, while twin 2 is normal. Obviously, we've done the torsion screen to rule out infection, amniocentesis of both twins, and NAT to rule out platelet antibodies. This is the second twin, which is normal, and this is the first one. You can see here the severe bilateral ventriculomegaly with the posterior horn of the lateral ventricle measuring 26 millimeter. She had an MRI on the same day, which confirmed the bilateral severe ventriculomegaly in twin 1 and the normality of the brain in twin 2. The torsion screen came back as positive for toxoplasma IgM and IgG for the maternal blood, and the amniocentesis came back as positive for both twins, positive for toxoplasma. So both twins were infected, but one was badly affected and the other one was normal. In this case, the treatment is a combination of the triple therapy, sulfadiazine, pyrimethamine plus folinic acid, and this is a detailed regime alternating with spiramycin. And of course, at birth, the baby needs to be examined in details, and the placenta also needs to be examined. And of course, the baby will need follow-up. So she comes later with the ventriculomegaly is getting worse, and she's requesting selective termination of twin 1, which is the affected twin with severe ventriculomegaly. So she had that, and 2 days later, she comes feeling unwell with a picture of abnormal raised urea and creatinine, as well as PCR, protein creatinine ratio, and raised CRP, while actually normal blood pressure, normal liver functions. And again, the next day, things are getting worse. So she's got acute kidney injury, stage 1. And we were thinking, what is that related to the toxoplasma? Is that preeclampsia or what? And the diagnosis was acute interstitial nephritis secondary to the sulfadiazine. So we need to be aware of this potential risk of sulfadiazine. Because she's 35 weeks already, we decided to deliver the normal twin, and treat the twin after birth, so they can actually get the same medication, but at least stop the mother from the need of continuing sulfadiazine. So she delivered the baby, which is fine, and then this is her renal function, so the urea and the creatinine, after the delivery and stopping the sulfadiazine, they went back to normal on day 9 when she was discharged. So be aware of, number 1, both can be infected, but only one will be affected badly, another one not. And also the risk of acute interstitial nephritis with the sulfadiazine. For selective reduction, there are a number of indications, including advanced TTTS, severe early onset selective vasoconstriction, TAPS, twin anemia polycythemia sequence, particularly in stage 4, especially if it's early onset. But also, of course, uncomplicated higher order multiples. We ought to have a discussion of selective reduction versus continuing the pregnancy, expected management, and this discussion ideally should take place in the first trimester. We need to be aware of this. The fact that actually in trichorionic triplet embryo reduction to twins does not improve the chance of survival, and that's been demonstrated in many studies. What it does is that significantly increases gestation and delivery, so reduces the risk of extreme prematurity and therefore the risk of disability. And therefore, the 3 options are either to continue the whole pregnancy, terminate the whole pregnancy, or embryo reduction from 3 to 2 or 3 to 1. If we do selective termination, ideally, it's better to be done in the first trimester, so 12 weeks compared to 20 weeks, because of the lower risk of miscarriage and preterm birth. And in triplet pregnancies, the risk of miscarriage and preterm birth differs according to the chronicity of the triple pregnancy, but also on the number of fetuses reduced. So if you see here, the group in blue is the trichorionic triamniotic triple pregnancy, and that's reduction, expected management versus reduction from 3 to 2 or 3 to 1. And the one in red is the dichorionic triamniotic triple pregnancy, again, expected management or reduction from 3 to 2 or 3 to 1. And you can see 2 messages here. Number 1, the risk of miscarriage, as you reduce more babies, increase the risk of miscarriage, but you reduce the risk of preterm birth. And the second one is the fact that in general, the risks tend to be higher in dichorionic triamniotic triplet compared to trichorionic triamniotic triplet pregnancies. Can we reduce one of the monochorionic pair in a dichorionic triamnitic triple pregnancy? And the answer is yes, using this very simple technique, the intrafetal interstitial laser that I mentioned earlier, ultrasound guided procedure. However, we need to be aware of, number one, that there is about 50% risk of loss of the co-twin, the monochorionic co-twin within 2 weeks. And number two, that actually it's not many cases reported in the literature and the experience is limited. And number three, that there is some concern about the neurological sequelae or neurological damage of the co-twin, the monochorionic co-twin. So really my take-home message is that scored anomalies in twins is complex and challenging and therefore require fetal input from fetal medicine specialists or experts in multiple pregnancy. Anomalies are more common in multiple pregnancies in singleton, and therefore you need to do a detailed anomaly scan. Crown rumblings or nuchal translucency discordance in first trimester are risk factor for the scored anomaly, and therefore you need to do detailed anomaly scan, consider testing for aneuploidy. Detailed anomaly scan in the first trimester is important because it allows earlier and safer selective termination in the event of discordant anomaly, as because the risk is higher when it's done around 20 weeks or in the second trimester. And in terms of the technical options, the choice would depend obviously largely on the technical expertise and what's available where you practice. I'm going to stop here and I'm happy to take any questions. Thank you very much for your attention.
Thank you. Thank you, Asma, for that wonderful lecture. I know it is hard to see any one twin suffering and everybody wants both the twins to go on well. But when in anomalies, how do you tackle? And this you have really clearly explained. People had lots of doubts whether when one of the twins is anomalous, do we consider that as a termination of pregnancy when we want to do something? Because here we have some MTP Act which limits the fetal anomaly as of now, right now. So probably that, but what is the routine in your place regarding the laws on termination when one fetus is anomalous?
Well, I mean, I work in the UK, so the UK, the law in the UK does allow termination or selective termination in this context. And certainly after 24 weeks, it is a legal option if the fetus has significant risk of physical or mental handicap. And that's up to the medical profession to judge whether, whether actually abnormality is associated with significant risk of mental or physical handicap. And the rule is that you need 2 medical professionals to sign a form to agree that actually that's a legal option.
I think that Amendment Act is coming into India, so all these problems will go off. It's already in the Gazette, but not yet into practice. Thank you, Asma. So we would have now.
I guess what you could, I think for twin or multiple pregnancy is quite actually unique situation. So despite the fact, and it was demonstrated nicely in the last case that was discussed in the previous panel, of the fact that there is an additional angle for twins, which is to protect the co-twin. So if you have, for example, a monochorionic twin pregnancy where, let's say, one of the twins have a lethal abnormality, or in the previous scenario with severe selective fetal constriction, with evidence of fetal compromise and high risk that this fetus will die, and the potential consequences to the co-twin, I think there's actually another angle that so you're doing it to save the healthy twin rather than to terminate the abnormal twin.
You are right. The responsibility for on us is to save that co-twin as well. Yeah. Thank you very much.
I think what you need to do is to actually educate. I guess it's similar to the UK. The people who make the law or vote is the politicians and the legal
policymakers
and the judges. And I guess what you need to do is that for you guys to explain to them, because such a complex scenario, and I think to educate them and actually maybe engage them in the fact that in a twin or multiple pregnancy, that's not just to terminate the baby that has abnormality, is actually to save the normal twin.
Yes.
It's
So
easier to
now-
sell, I think.
Correct. We are into a transitional phase of that amendment. So it is still not into practice. So maybe in due course that will happen. Thank you so much, Asma. We will hear to you again after some time. We will give you a small break. Meanwhile, we will be listening to Dr. Suresh. So over to Dr. Hepzibah. Hepzibah.
Am I audible? Good evening. Am I audible, Vijay?
Yes,
yeah,
madam,
now-
you're audible, madam.
Yeah.
Yes, Hepzibah. Thank you so much for co-chairing with me. Yes, Hepzibah.
We'll move on to the next interesting session, talk by Dr. Suresh. I think he's the right person to do this because he's the first person to start a diagnostic and fetal therapy center. And he's the first Indian institution recognized by the Fetal Medicine Foundation UK. And their Mediscan system does a lot of charity things. They support a lot of children affected by storage disorder. And he has established a special unit for twins with the facilities of fetoscopy, laser for monochronic twins. And he's above all, he's a very simple and down-to-earth person. All the government colleges from Chennai, whatever little doubt we have, we refer that case. And patiently, he will do it and he will immediately call us and inform what to do, what best we can do. And he's the right person to talk about TTS, tops, traps, etc. Over to Dr. Suresh, sir.
Good evening. Are you able to hear me?
Yes, sir, we are able to hear you.
Slides are visible. Okay.
Louder.
Good evening to you. Thank you very much for this kind opportunity. And after that lovely lecture by Asma, we will see some aspects of twin-twin transfusion syndrome, SFGR, and twin anemia polycythemia sequence. The title given was Getting It Right, and I believe that getting it right means getting the diagnosis right, getting the management right, and getting the outcome right. So that's what we will try to see. Now, as we know that monochronic twins can get into complications, 14% of them will have discordancy in the growth, which we call as selective fetal growth restriction. 9% will have twin-twin transfusion syndrome, and just 1% will have twin anemia polycythemia sequence. And but the most important thing is these conditions like TTS, selective fetal growth restriction, and TAPS can coexist with each other, and any of them you can have a single fetal demise with a consequence for the other twin. Now, anomalies, discordant anomalies in twins, in monochronic twins is about 10%, but we are not going to consider that today. The key thing here is to have a correct diagnosis and appropriate management. So how do we follow up monochronic pregnancies? We start by the 12-week NT and CRL with the ductal.
So sorry to interfere. Your audio is low, sir. We are getting the message from the chat box.
Okay, 1 minute. Yeah. So, is it better now?
Yes, sir. Yes, thank you.
Little better, sir.
Okay, so the after 12 weeks, we do a scan at 16 weeks. And during the 16-week scan, we do the umbilical artery and the ductus venosus Doppler. We look at growth and also Leica, and we map the site of cord insertion. I'll tell you why we do that. And of course, the intertwin membrane. Now then, from then onwards, from 16 weeks onwards, we do 2 weekly Dopplers to look at biometry and Doppler of the umbilical artery, middle cerebral artery from 18 weeks onwards with the peak systolic velocity and ductus venosus. Then, of course, most important thing is we should look at the fetal heart to look for any signs of enlargement where it could be a coexisting twin-twin transfusion. Now, if you want to understand TTTS, we should need to understand monochronic placenta and the vascular anatomy. So here is a placental vascular anatomy where we have the artery and the vein from one twin and the other having an anastomosis. There is a dividing membrane which decides the two sacs, and you can see the vessels crossing over from one side to the other side. Now, the anastomosis are deep in the cotyledon, which are called the arteriovenous and the veno-arterial anastomosis. And there are superficial arterio-arterial and veno-venous anastomosis. The vascular flow is usually bidirectional, and there is a net balance of flow going from one fetus and coming back from the other, and that's usually maintained in about 85% of the individual. There are also the balance of the pressure on both sides is maintained by the arterio-arterial anastomosis in the superficial part of the placenta. So here you can see this picture which gives you the anastomosis. The green is the vein and the yellow is the artery. You can see the artery of one is anastomosing with the vein of the other. They tip down into the cotyledon and the anastomosis actually plays deeper in the cotyledon. But here you can see the two yellows actually communicating with each other. That is the superficial arterio-arterial anastomosis. Now, in the placenta itself, you can see all these anastomoses are almost in a line, and this line is called as the vascular equator of the placenta. As compared to here, you can see a membrane that's called as the membranous equator. Then you can see the cord insertion sites. One is a central cord insertion, the other is a velamentous cord insertion. So the problem in twin-twin transfusion is the imbalance of blood flow. The recipient has more volume flow, polyhydramnios results, and cardiac overload also results. And in the donor, there is less volume and thus oligohydramnios. The diagnosis of twin-twin transfusion is done when the single deepest vertical pool in the sac, in the donor sac is less than 2 centimeters, and in the recipient sac is more than 8 centimeters. This is otherwise called as oligo-poly or twin oligo-poly sequence or TOPS. Now, the modified criteria for diagnosis says that if the gestational age is less than 18 weeks, then the polyhydramnios in the recipient, even if it's above 6, it is still called as twin transfusion. After 18 weeks, it is more than 8, and after 20 weeks, it should be more than 10 centimeters, while 2 centimeters is remaining the same. Now, we do 2 weekly scans in monochromatic if there is amniotic fluid discordance between the twins, but not fulfilling the criteria of 8 and 2, then, and it continues like that, there is a 93% good outcome in such cases. Now, staging of TTTS, as we all know, has 4 stages, stage 1, 2, 3, and 4. Stage 1, where there's just a Likert difference with both bladders being seen. Stage 2 is when the bladder is absent, and stage 3, in stage 2, here you can see a stuck twin, bladder is absent, and stage 3, you have abnormal Dopplers, and stage 4, you have eye drops of one twin, and possibly this will lead to impending fetal demise. So the options for treatment for twin-twin transfusion syndrome, fetoscopic selective laser photocoagulation of anastomotic vessels is the most definitive treatment. But there is also a treatment of amnioreduction, and the management is completely dependent on the gestational age at which the patient presents, and also the stage at which the TTTS condition is. Now, between 16 to 26 weeks of gestation, fetoscopic laser ablation is the method of choice. And if you do that, there is a 76% chance that there will be at least one survivor. There is also a lower incidence of periventricular leukomalacia in the surviving twin as compared to amnioreduction, which has got a higher percentage. And babies which are free of neurological complications at 6 months of age is 52% in laser versus 21% in amnioreduction. So overall, there's 11 to 14% risk of long-term neurodevelopmental outcome, but these figures are variably quoted in the literature. But one thing we should say is between 16 and 26 weeks, laser photocoagulation is the treatment of choice for twin-twin transfusion. Now, what happens after 26 weeks? After 26 weeks, we can consider amnioreduction and also laser photocoagulation till about between 26 to 28 weeks, because there will be limitations due to visibility, the because of the vernix, the vessel size will be larger, and the fetoscope length also needs to be larger. So current evidence that lasers can be done after 26 weeks with similar outcomes, but we choose it on a case-to-case basis. Now, we come to the question of stage 1 TTTS. We discussed stage 2 to 4 TTTS. Stage 1 TTTS, where the good bladders are seen on both sides, there's like a discordance. And if there is no maternal discomfort from uterine distension, cervical length is greater than 25 millimeters, we can do expectant management with weekly amniotic fluid, 2 weekly Dopplers, and also growth every 3 to 4 weeks. Now, if there is maternal distress or uterine distension, severe polyhydramnios, cervical length greater than 25 millimeters, the choice is to do fetoscopic laser ablation, even in fetoscopic laser in stage 1 TTTS. So the optimal initial management of stage 1 TTTS remains in equipoise. There are different centers who manage it differently. Now, what happens if it is stage 1 TTTS after 26 weeks? As I said, if there is severe maternal discomfort, we can do amnio reduction. It may improve TTTS sometimes, and weekly follow-up with Dopplers and reduction if needed. The limitations for laser are poor visibility due to vernix, large caliber of vessels, and of course, distance scope limitations, as I said earlier. Now we move on to selective fetal growth restriction, and the diagnostic criteria to call it a selective growth restriction are reasonably fixed. When one of the fetuses, the estimated fetal weight is less than 3rd centile, and at least 4 of these parameters, where estimated fetal weight of one twin is less than 10th centile, AC of one twin is less than 10th centile, estimated fetal weight discordance of greater than 25%, and umbilical artery PI of smaller twin greater than 95th centile. Now, once you see SFGR, we also need to look at discordant cord insertions, because here you see a central cord insertion and a marginal cord insertion, and that also decides the amount of territory shared by each fetus. So this fetus is sharing a smaller area of the placenta, whereas this fetus is sharing a larger area of the placenta, and here you can see a velamentous cord insertion. So in our own series, we find that when there is a selective growth restriction, 69% of them would have marginal or velamentous insertion. So we map the cord insertions as early as possible. The next thing is to do growth, Doppler, and Leica by 2 weekly monitoring. The Leica can be concordant in both the sacs. The Leica can be normal in the normally growing twin and oligohydramnios in the smaller twin, or it can get stuck, as you see here, to get a stuck twin, and the Dopplers can also be either normal, or the umbilical artery Dopplers can be abnormal in that. So once you see an umbilical artery or Doppler abnormality, we divide that into 3 types. We call it as type 1 when there is forward flow in the umbilical artery in the smaller twin, type 2 when there is reverse end diastolic flow continuously in all the cycles, and type 3 where there is intermittent absent and reverse diastolic flow in the smaller twin. Now this is important to know, because the way the reverse diastolic flow behaves in a monochronic twin is completely different from a singleton pregnancy. We don't draw the same conclusions as in a singleton pregnancy. These are done to understand the nature and the type of the anastomosis which is there, and to prognosticate the fetus. There is a small issue here that this does not consider gestational age diagnosis, and also the ductus venosus Doppler is not considered. So the new classification of SFGR is according to the gestational age at diagnosis: early onset less than 24 weeks, late onset is greater than 24 weeks. And according to the Doppler of the umbilical artery and ductus venosus of the smaller twin, we have stage 2, which is umbilical artery 2A, which is persistent absent end diastolic reverse flow, and intermittent is 2B. Stage 3 is abnormal ductus venosus. Stage 4 is superimposed TTTS, and stage 5 is IUFT of the smaller twin. So the threshold for treatment here is when there is greater than 35% discordancy, type 2 or type 3 SFGR, and ductus venosus of the smaller twin greater than 90th percentile, or when there's a stuck twin and any two of these parameters can also be sent. Once you say treatment for SFGR, we have three options. One is we can do laser dicoronization of the cord. We can draw a line and saying that we are completely separating the placenta. This might sometimes actually compromise the supply of the other twin, and we can have an intrauterine fetal death. The other thing is, of course, bipolar cord coagulation, where of the smaller twin, we might have to fill up amniotic fluid and saline into that sac and then go for a bipolar cord occlusion, or we can do radiofrequency ablation, which is also an accepted method. Now, what we are interested in is what are the outcomes. If there is a type 1 SIUGR, the live born will be 96%, in expectant management, intact survival will be 97.8%. With laser or selective fetal reduction, of course, it's almost 100%. So there's really not much of an advantage of doing any procedure in a type 1 SFGR. But in type 2 SFGR, with expectant management, the intact survival is about 89%, perinatal demise is 14%. With laser, perinatal demise of the smaller twin will be 46%, but intact survival of the other twin will be 100%. Now, in type 3, you can see with expectant management, it's only 61% the babies will survive. With laser, that's 100% survival. And with selective fetal growth restriction, there's a 98, selective feticide, there is a 98.8% survival of the smaller twin. So the optimal management SFGR, we need more robust evidence, but type 1 SFGR, expectant management in most cases, good perinatal outcome. Type 2 and type 3 SFGR, higher perinatal mortality and morbidity. Fetal therapy may have a role at less than 24-26 weeks in severe cases in order to protect the surviving twin from demise or neurological damage. Selective fetal reduction better than laser due to technical difficulties and surgical complications during fetoscopic laser. Lastly, I'll tell you about twin anemia polycythemia sequence, which is actually a chronic fetal transfusion in monochronic twins through small minuscule anastomosis which may be present, and there can be large hemoglobin difference between the twins without oligo-poly sequence. And spontaneously it can happen in 2 to 5%, post-laser in about 3 to 16%, not detected antenatally but after birth in almost 40 to 63%. So the current method of diagnosis of TAPS is when the MCA peak systolic velocity is greater than 1.5 mom in one twin and less than 1 mom in the other twin, which is a polycythemic twin. It's got a sensitivity of about 46%. A new proposal is to use what is known as the inter-twin difference in the MCA-PSV mom, otherwise called the delta MCA-PSV mom. If the delta MCA-PSV mom is greater than 0.5, it has got a sensitivity of about 83%. You can also look at the placenta, where the two portions of the placenta look completely different, and the liver can have a hypoechoic appearance in the polycythemic twin called starry sky appearance. Now, TAPS can also be staged. I won't go into too much details, but just to say that as the MCA-PSV increases, the baby becomes more anemic. There's a cardiac compromise of the donor twin and has a critically abnormal flow, and then it can lead to high drops and also demise in that way. So that's why we need to institute some form of treatment. So management for TAPS can be expectant management by close monitoring and delivery at the appropriate time. Intrauterine transfusion, intraperitoneal transfusion is preferable because you can take blood from the polycythemic donor fetus and inject it into the peritoneal cavity of the other twin. Fetoscopic laser surgery, IUT followed by fetoscopic laser surgery, and IUT with partial exchange transfusion for the polycythemic twin. So whom are the cases which we try to treat? If the gestation age is less than 28 weeks, it is stage 1 TAPS, expectant management. If it is stage 2 TAPS, then laser treatment can be tried. If 28 to 32 weeks, if it is stage 1, expectant management, stage 2 and it's progressive, you can give intrauterine transfusion, or even stage 3. And if it's greater than 32 weeks, if it's stage 3, we can plan delivery, or if it's stage 1 or 2, we can still do expectant management. So the long-term neurodevelopmental outcome, could be mild or moderate cognitive delay in 9 and 17% of TAP survivors. No difference between donors and recipients. Risk factors for decreased cognitive scores are low gestational age at birth and low birth weight, as well as intrauterine transfusion. Now, severe long-term morbidity such as bilateral deafness and spastic paralysis has also been reported. So currently, there is no consensus on optimal method of management, so we do it on a case-to-case basis. So in a nutshell, MCDA twins need close monitoring, 2 weekly or weekly monitoring, map cord insertions, do the growth on Leica, Doppler of the umbilical artery, medial cerebral artery, and ductus venosus. Any discordance, refer to a specialist. If you look at the Leica, normal or oligo or reduced Leica, anomaly in one twin, SIUGR or PROM. Normal or poly, rule out anomalies, close surveillance for evolving problems. If it's oligo-poly, then it could be twin-twin transfusion. So Leica discordance is a very important thing to come to a conclusion. So we plan appropriate treatment based on diagnosis and gestational age. Thank you very much for a patient listening on this opportunity.
Thank you very much, sir, for the in-depth lecture on the twin-to-twin transfusion, right from the basis of vascular anastomosis, the problems in twin-to-twin transfusion, the modified criteria for its diagnosis, and the management depends upon the gestational age and that depends upon the Doppler changes, and about the selective FGR, how to diagnose on based on Doppler and the Leica, and the new classification of FGR and the different method of FGR and different age, how we are going to manage. And again, talking about the perinatal outcome also depends upon the age at which we intervene. And the TAPS, again, the diagnosis is based on MCA PSV and it depends upon the staging. The management depends again on gestational age and how it's going to affect the long-term neurological defect. It's very well dealt and in depth in a short time. You have covered everything. Thank you so much for the interesting, excellent talk, sir. Thank you so much.
So now we move on to the third lecture of this session and the last, but definitely the not the least interesting, which we are over to Asma again. May I call upon Asma to talk on fetal growth in multiples. Yeah, Asma, back again to you. Looking forward to listening to you on fetal growth in multiples.
Okay, well, actually, well, interesting, because I sent my recorded
yeah.
talk.
Do you want that to be played?
Yeah, we can play that.
Yeah?
Yeah.
I'm happy to play it as well from my computer, but also happy to give the lecture.
No, whatever you want to
say. If you're, yeah, either way, whichever you're happy to do.
Okay, let me just play it for you then. 1 second. I'm sorry about that.
Do you want us to play, Asma?
Sure, sure. Yeah.
Hello everyone, this talk is on selective feeder-based instruction.
You can get Chitra to play also.
I am doing it.
Okay.
Second.
So first we have to monitor restriction.
Can you hear it?
No, Asma. We can't. I think you need to share audio, share sound.
Yes, yes, I know that. Okay. I thought I am advancing option.
Okay.
And how do you do the?
The tech team is ready, actually. I can get them to share it with you.
Okay, well, why don't we do that? But I think,
Yeah.
oh, here we are.
Okay.
I can do that now. Okay.
Hello, everyone. This talk is on selective fetal growth restriction in monochorionic twins. So we'll first of all have to monitor actually for fetal growth restriction in twins. And this flowchart has been published in a number of guidelines, including the ISWA guideline, where if you have dichorionic twins or monochorionic twins, you do the first trimester scan, and dichorionic twins from 20 weeks every 4 weeks until the end of the pregnancy, where you measure the biometry of both babies and you estimate fetal weight discordance, and you look at the amniotic fluid and assess the Dopplers. Monochorionic twins, you do a scan every 2 weeks from 16 weeks until the end of the pregnancy. And again, obviously monitoring for twin-to-twin transfusion, but also for fetal growth restriction. About the use of Dopplers, in ISWA guideline, we did recommend that we should be doing the Dopplers, particularly from 20 weeks. However, other guidelines do not necessarily agree. So American College of Obstetrics and Gynecology, they do state that actually the use of umbilical artery Doppler in women with uncomplicated dichorionic twins is not associated with improved prenatal outcomes. There's no evidence. That routine assessment in umbilical artery Doppler is beneficial in the absence of growth or fluid discordance in monochorionic twins. So there is some discrepancy in the guidelines. So we are focusing on the monochorionic twins. So you can see the flow charts. So from 16 weeks, every 2 weeks until the end of the pregnancy. And in each scan, you measure both babies, you estimate the fetal weight discordance, and you measure the deepest vertical pocket, and you assess the Dopplers. So how do we diagnose selective fetal growth restriction in twins? Well, if you have one of the baby have estimated fetal weight less than 3rd centile, that's enough to diagnose selective fetal growth restriction. Or the more commonly used definition, and the one I prefer, is if you have the either estimated fetal weight less than 10 centiles, so it's a conventional cutoff, plus either discordance of 25% or more, or abnormal umbilical artery Doppler. So this is a case of selective fetal restriction in a monochorionic twins, where you can see there is a striking difference in the size, the smaller twin and between the larger twin, and the smaller twin often will have oligohydramnios or reduced amniotic fluid, and the larger twin have normal amniotic fluid. Once you make the diagnosis, you need to assess the umbilical artery Doppler in order to classify it according to the Gratagas classification into type 1, type 2, and type 3. And type 1, as you can see here, there's a positive in the systolic flow in the umbilical artery Doppler, and type 2 in the middle, where you have absent or reverse in the systolic flow in umbilical artery, and type 3, which has this characteristic pattern of intermittent absent or reverse in the systolic flow in umbilical artery Doppler. These types do, to some extent, have prognostic value. So type 1 often have good prognostic value with low risk of progression, low risk of demise of the smaller twin, while type 2 is probably the worst, with high risk of progression and high risk of demise of the smaller baby. And type 3 tend to have unpredictable pattern with risk of demise of the smaller baby and potential consequences to the larger twin. Over the last few years, we've done a number of studies to look at the natural history of selective fetal growth restriction in monochorionic twins. And we learned a few things. So we learned if you classify a selective fetal restriction in monochorionic twins according to early and late, with a cutoff of 24 weeks, sort of the viability, and also with a cutoff for active fetal intervention. So you find that actually about 5% of monochorionic twins develop early selective fetal restriction before 24 weeks, and another about 4 to 5% late selective fetal restriction when diagnosis is made after 24 weeks. What about the types that I showed you before? So the early selective fetal restriction, 80% of them are type 1, which is the best one. 14, or let's say 15% type 2, the worst one, and only about 4 to 5% is type 3. In our series, the late selective reconstruction, 95% of them were type 1, which is a good prognosis, and only about 5 to 6% were type 2. We did not have any type 3. As I mentioned earlier, these types do have some prognostic values, so the progression is highest in type 2 selective fetal reconstruction. And again, in our series, the gestation age delivery was about 34 weeks in type 1, about 31 weeks in type 2, and about 32 weeks in type 3. What are the risk factors for demise of the smaller twin? Well, again, in both in type 1 or type 2, we had the gestation age diagnosis. The earlier the gestation age diagnosis, more severe, and therefore the higher the risk of demise of the smaller baby. And also we found that the ductus venosus Doppler also is associated independent predictor of the risk of demise of the smaller baby, particularly in type 2. Management of these pregnancies tend to be quite complex because the demise of the smaller baby have about 30% risk of the demise or brain damage of the larger twin. And therefore their options are is either expectant management, so monitor these pregnancies carefully and deliver early after a course of steroids, or active fetal intervention in the form of either laser surgery or selective reduction, often by cord occlusion. So these are the management options, either expectant, laser, or cord occlusion. And there are no randomized controlled trials to guide us which management is the best. It's not like TTTS, where you have randomized controlled trials and Cochrane reviews to tell us that laser is better than amnio drainage. So we attempted to look at or compare the outcomes in the various groups, so the different types according to Kratakos classification and also according to the management, one of the 3 options I showed you before. And we published that a few years ago in a meta-analysis. And we looked at a very large number of outcomes, including risk of demise, intrauterine demise or stillbirth, neonatal death, neonatal morbidity, survival without neurological problems, very long list. And I'm not gonna take you through all the results of the outcomes because of the time, but I'm just going to show you, demonstrate a couple of outcomes just to make a point. So in type, so if you look at the intrauterine demise, and this is type 1, this is type 2, and type 3, and each one is so expectant is a black, laser is a blue, and red is the cord occlusion. And this numbers is the instance of this outcome. And you see that actually in type 1, the risk of demise with expectant management is very low. Therefore, you cannot really justify active fetal intervention. While type 2, the laser had a higher risk of demise with a type 2 and type 3 compared to expectant management and cord occlusion. But it's also important to understand that by definition, cord occlusion, obviously, there's only one baby left. What about overall morbidity? You see, again, in type 1 is low, the risk is low, while type 2 and type 3, you see the opposite pattern. So laser is associated with lower risk of morbidity compared to expectant management or cord occlusion. And therefore, what we concluded in this meta-analysis is that type 1 have good perinatal outcomes and should be managed expectantly, while type 2 and type 3, it seems from the data and its observational data, so obviously this potential risk of bias, that the fact that laser has higher mortality but lower morbidity compared to expectant management, and therefore we will only consider active fetal intervention at early gestation, so removed from neonatal viability, and the fact that these cases, as I mentioned, the management is complex and need to be individualized, take into account the gestation at the age diagnosis, because the earlier the diagnosis, the higher, the more severity and high risk of demise of the smaller baby, how severe the cross discordance, and obviously the Doppler abnormalities. And I'm just going to show you this case. So this is a lady that was referred 16 weeks plus 5 days, and you see twin 1 is much smaller. The biometry is all below the 10th centile, and the second twin is normal with normal amniotic fluid volume. And see, this is the umbilical Doppler in the smaller baby, so absent in the diastolic flow. But it's interesting that you see when you follow up this pregnancy, so at 18 weeks, you see that actually the Doppler does change. So sometimes it becomes positive in the systolic flow in the umbilical aortic Doppler. So you can see there is actually a degree of the pattern of the umbilical aortic Doppler can vary. And that's been reported in the literature. And therefore, there is some problems with the Gatakos classification, the one I showed you earlier. So number one, it does not take into account the variation in the pattern of umbilical aortic Doppler. Sometimes it becomes from negative, becomes positive, or the opposite. And as that's been reported, that the fact, what about if you have superimposed or coexistence of twin-to-twin transfusion syndrome, and the gestational age diagnosis with early onset and mid onset, and I showed you that's an independent predictor of the risk of demise of the smaller baby, and also the ductus venosus Doppler. And therefore, we have proposed another classification. And how do you follow up these pregnancies? And when we wrote the ISWA guidelines, we did recommend that in monochorionic twins complicated by selective fetal restriction, it should be seen at least weekly to do the Dopplers. If there is signs of progression, maybe even perhaps more often. And if there are signs of substantial risk of fetal demise of the smaller twin, like reverse airway in the ductus venosus, the management will depend on the gestation. So if it's beyond 26 weeks, you should consider actually delivery after a course of steroids. And if it's before 26 weeks, with the risk or the outcome is likely to be poor for both twins, in this case, you should consider the option of active fetal intervention, including the option of selective termination. When to deliver these pregnancies? Well, in type 1, as I said, the good prognosis, low risk of progression, we can carry on until 34, sometimes 36 weeks, and deliver after a course of steroids. In type 2 and type 3, where there's a higher risk of demise with a smaller baby, the guidance is at 32 weeks, the latest, or earlier if there's signs of progression of the deterioration. But it's important to highlight that these are based on observational evidence and really consensus rather than from randomized controlled trials with robust evidence. But the other thing is that if you see these cases, you will understand that things are not black and white. Sometimes the pregnancy starts with maybe a degree of immunofluid discordance, size discordance, and then progresses to either twin-to-twin transfusion syndrome or selective fetal restriction, or superimposed, so selective fetal restriction to start with, and then get superimposed CTTS or TTTS, and then you do the laser, and then you're left with selective fetal cross restriction. And therefore, it's really important to have the diagnostic criteria clear in your mind, in your brain. So TTTS, it's a polyhydramnios oligohydramnios sequence. You must have polyhydramnios diagnosed twin-to-twin transfusion syndrome. Often there is large size discordance, but in acute TTTS, they are usually often of similar size, so there's no large size discordance, while selective fetal cross restriction is mainly large size discordance, more than 25%, and one of them is small, less than 10 centile, but often there is no polyhydramnios. So the larger twin have normal amniotic fluid, and the smaller baby can have oligohydramnios. So what's the chance of superimposed TTTS in monochorionic twin pregnancies complicated by selective fetal restriction? Well, it varies according to whether early or late. Remember, I told you early onset, less than 24 weeks. In these cases, the chance of superimposed TTTS is about 27%. So 1 in 4 or 1 in 3 will get superimposed TTTS, while in late selective fetal restriction after 24 weeks is only about 5%. Chance of superimposed TTS, and often, because we know that TTS often occurs before 24 weeks. It's also the superimposed TTS varies with the types. With Gatakos type 1 is about 13%, while type 2 is much higher, is 60% chance of superimposed TTS. So another case, so this lady was referred at 18 weeks. You can see again the twin 1, the biometry is completely normal. Twin 2, the biometry is less than 10 centile with oligohydramnios, and you can see that in the images there, and very large striking size discordance. The discordance was 61%, and therefore you discuss the management options, and also this baby had absent in the solid flow umbilical aortic Doppler, as you can see there, and therefore is type 2 selective fetal restriction. You see here, this is the bladder of the larger twin, with normal amniotic fluid volume. And therefore, the woman decided to have laser. She didn't really want to have selective awkward occlusion or selective termination. From my experience, most parents don't want to have, they struggle with this decision. So, so she had the laser, this lady, at 20 weeks. And the following week, at 21 weeks, was same findings. So the smaller baby was still alive. Obviously, she's been warned that there is a high chance that the smaller baby will demise after the laser. So the following week, both fetuses are alive, and then the following week, the smaller twin died, and the larger twin was alive with no signs of fetal anemia. To me, my take-home message is that you need to have uniform standard definition of selective fetal costal restriction. In monochorionic twins, yes, it happens because of unequal placental sharing, and sometimes the smaller baby is dependent on the larger twin. So the last case, after the laser, we warned the parents about the high chance of demise of smaller baby, and the reason we do the laser is to protect the larger twin from the consequences of demise of the smaller twin. The survival of selective fetal constriction differs according to the type, and I showed you this data. Risk factors for demise of the smaller baby, the independent risk factors is gestation age at onset and fetal Doppler, particularly the ductus venosus Doppler. I didn't show you this data because of the time, but the presence of TTTS does not seem to influence the outcome. And often, if there is TTTS, we will offer laser surgery. These cases are complex, their management and counseling is complex, and therefore the recommendation is to refer them early to a fetal medicine expert, because even the decision or the timing of the delivery is not straightforward, because you need to balance the risk of demise of the smaller baby versus the risk of prematurity, particularly for the larger twin. And be careful of the data that's published, because comparison of survival data according to treatment using observational data is likely to be biased. And thank you for attention, and I'm happy to take any question.
Thank you, Asma. That was nice. And we could see two of you, so that was even better.
I did record it because of the the time,
Yeah,
the
yeah,
initial program,
yeah, yeah.
I was not
Yeah,
available in a place where I can have network.
But
So
thank you so much. You took the effort of recording and sending, and so nice. Thank you so much.
Pleasure.
And of course, we had almost everything about the growth monitoring and everything, and what do you do when there is a discordancy and everything. I think, do we go for the poll, Uma?
Yeah, while they collect the questions, we can have an audience
Just tell
poll.
how to go about it, because some audience, I think.
Yeah. So in the poll questions will be flashed, and I request all of you to take time and respond to the questions. We'll keep them for some time. Chitra?
Tell them just that you have to press on the option.
Can you start the poll? The option for fetal reduction in a monochorionic twin would include intracardiac injection of lignocaine, intracardiac KCL, RFA cord occlusion. Selective reduction is possible only in a DC twin. I think more of you can participate and press on the button. Okay. All right, so 63% have said RFA cord occlusion. In a monochorionic twin, you cannot do intracardiac injections because of the shared placental blood supply. Selective reduction is feasible. You've just heard two fantastic talks about how that can be done safely. And RFA or cord occlusion are possible options, or as Asna mentioned, intrafetal laser as well. Next one. This is simple. Monochorionic twins have the same number of anomalies as dichorionic twins. Okay. All right. So yes, the chances of anomalies are higher in a monochorionic pregnancy than in a dichorionic pregnancy. We move on to the next one. Okay, so in a monochorionic pregnancy, MCA Doppler is important to identify which condition. Hypoxia in the fetus, SIUGR, TTTS, TAPS. Okay, so for making a diagnosis of TAPS, MCA Doppler is very important. I mean, any hypoxic fetus, you will see the MCA Doppler going up, but in terms of making a diagnosis of those conditions, TAPS is the correct answer. Next one. An MC twin at 22 weeks, fetus A with a SVP of 3, single vertical pocket of 3, and a fetus B with a single vertical pocket of 6. There's a 15% weight discordance and normal Dopplers. What's your diagnosis? Okay, so we'll come back to this also in the discussion time. Can we move on to the next question? What is significant size discordance? Is a weight difference of? We'll get Asma to comment on these as well.
Yeah, I think Asma can take this.
Okay. So more of you have said 25 than 20. And we've just gone through the reasons of, the changes in nomenclature and how gestational age is important, etc. with the new definitions. We'll move on to the next one. I think that's the last one, isn't it? The management of growth restriction in a dichorionic twin is the same as a singleton. Okay. Okay, 38% said false. Actually, you do manage a dichorionic twin in a similar fashion to a singleton. Okay, so with that, I mean, Priya, have you got the questions? Citra, can we go back to gallery mode? I think we have Asma to answer the questions for us.
Okay. The first question, madam. Selective fetal reduction is allowed in the MTP Act. The question is for India. People want to know, like, till how many weeks can we go for selective, reduction? And does it come on the MTP Act?
Yeah, Priya, let's handle the other questions first.
Yes, ma'am. 1 second.
So
after selective fetal demise of an anomalous fetus of more than 24 weeks, can we monitor the mother with a coagulation profile weekly? A selective fetal reduction or a fetal demise of an anomalous fetus after 24 weeks. Can we monitor the mother with coagulation profile weekly?
I don't think we need to monitor the mother with coagulation profile weekly. It is true that it's probably the old literature highlighted the risk of DIC in the mother who had a intrauterine demise or stillbirth. I suspect this relation because of maybe abruption. So abruption causes stillbirth, and also abruption that's severe enough to cause stillbirth is likely to cause DIC in the mother. However, certainly from my experience and from the recent literature, if you have a twin pregnancy, whether dichronic or monochorionic, if you have one baby that had died, whether you single intrauterine demise, spontaneous demise, or you did selective termination, the risk of DIC or coagulopathy to the mother is extremely low, and therefore we don't monitor the mother for coagulopathy.
Okay. Will you have a different opinion if the demise happens after 30 weeks or 35 weeks?
No.
If a single fetal demise?
No, same answer.
Yes. And the next question
I
I'm
think
going
the
for, madam.
other thing which I think is important to mention, a lot of these women either will deliver, so especially when the demise occurs at late, and we publish that, when the demise occurs in the second half of the pregnancy, or particularly in the latter third of the pregnancy or in the third trimester, the risk of preterm birth is very high, whether spontaneous or iatrogenic. So whether actually us doctors deliver early because we worried about the other one, or because the parents are worried about the surviving twin. So there is element of medically indicated or iatrogenic preterm birth, but also there is increased risk of spontaneous preterm birth.
So
I
Asma,
take
I have a question for you, Asma. You had said that in fetal growth, selective fetal growth restriction, after 26 weeks, probably we need to steroid and deliver. And I think that is valid in the context of countries where 27, 26 weekers do well. So we often have a dilemma when we have somebody who presents at 26, 27 weeks with a fetus which is pretty sick, where we may end up having to offer a procedure which is technically challenging at that gestational age because the babies are bigger, because fetal survival or neonatal survival isn't very good at that gestational age. Any thoughts on that? I know there isn't evidence because none of us are picking out the numbers. Maybe we should start doing something about it, but your thoughts?
I think it's very good point. And in fact, I think we did discuss it, and we just published a state of art article in the Y journal. It's literally it's June 2020, so it's coming up, but I think it's available and it's free to download, I think, in the next couple of weeks. Okay. So, and we did discuss this exact precise point, and I think Suresh in his talk, I think he sort of alluded it. This new classification was in the controversies paper, controversies in twin pregnancies. So I encourage you to read it, because I think we discussed this exact point, is the fact that is 26 weeks when we included in the guideline, in the ISWAC guideline, was mainly really consensus, sort of a group of experts sitting in the office, in the ISWAC office in London around the table. But you're absolutely right, is that the 26 weeks would vary, because if you work in a place where neonatal unit survival at 26 weeks is very low, maybe actually you shouldn't really deliver 26 weeks. And in fact, even where I work, and I had a case recently where the 26 weeks, but the small baby is only 300 grams. well, this baby has no chance. So why would you deliver? So, and therefore, you're absolutely right. I don't think this is black and white, and you have to apply whatever guidelines to your local practice, and the guideline itself for you to update it in the second half of 2021. So hopefully that will get maybe addressed or rectified, or actually highlighting this point that this cutoff can vary with gestation. I think the challenge is that what to do with this pregnancy, because if it's 26 or 27 weeks, and particularly if you have anterior placenta, laser is going to be very difficult, very challenging. And in fact, actually you have a risk of hemorrhage or rupture of some of the blood vessels, and therefore this risk of actually demise of the larger twin, which obviously you want to protect. Selective fetal or selective termination or cord occlusion is an option. But of course, it depends where you work, and it depends on the law, not the legal regulations where you practice.
Okay. Thanks, Asma. That was clear. My other question is, I know we all talk about Dopplers when we are monitoring these babies with selective growth restriction, selective reduction in monochorionic twin. Where would you place the role of CTG here?
There's hardly any evidence. There's nothing published really on the role of computerized fetal heart monitoring. And if you do have any data, get in touch with me, because we are collecting data now to look at that. And I started also relying on them, because it's difficult to, you can't scan them every day.
Yes.
And particularly at a late gestation where you're trying to prolong the pregnancy to improve the neonatal outcomes or reduce the neonatal morbidity. But also you don't want to you don't want to take the risk of demise of the smaller baby. So actually I started also doing the fetal heart monitoring in conjunction with the scan, with the Doppler, particularly for example over the weekend. So when maybe there is no fetal medicine expertise available to scan this mother, but there is no data.
Yeah, because we had a couple of cases where we were at 32 weeks, 33 weeks waiting to deliver, and the Dopplers were normal the day before, but then the CTG was showing decelerations, and then we pulled out the baby, and I looked for evidence, and there was hardly anything. And then somebody had queried, do I wait with the 34-weeker with a growth restriction if the Dopplers are normal? And I just wondered about the role of CTG there. As you say, because we often don't get the expertise needed to scan and do a Doppler on these babies at such frequent intervals, even if you're in a center which has the FMU
yes.
Next door.
Yeah. Yes, absolutely. And the truth is that people don't like scanning twins. They're more difficult, they're more challenging, and particularly when you have a selective fetal growth restriction, when scanning the smaller babies is really tricky. And there is obviously, you have to have the relevant expertise, because otherwise you can confuse the twins. So so it is true that sometimes can be challenging. Despite the fact, normally I would say the ultrasound is more reliable than fetal heart monitoring. That's what we usually believe in. But actually, as I showed you in the case, the Doppler from my experience, umbilical artery Doppler in selective fetal constriction can vary with gestation, can change, and therefore I think if it depends on the abnormalities on the CTG, on the fetal heart monitoring. We use computerized fetal heart monitoring, so if you have short-term variation that's very low, for example less than 3, I would deliver, because that's maybe carries a risk of demise with a smaller baby, and there's consequences to the larger twin, and particularly after 34 weeks when the outcomes for both babies will, particularly the larger one, should be good.
Okay, thank you very much. Thank you.
So, Asma, just wanted one sec. Asma, now we are all talking about twins, that's fine, but like how often do you think all the triplets, do you find them often, and if so, do in every triplet you reduce them to twins, or you allow in your place?
Well, I mean, certainly, of course, triplets are not very common, but in my center they are, because they get referred. And the guidelines is that you should offer all triplet pregnancies the option of expected management or selective reduction, and that should happen in the first trimester. And therefore, that something should be offered to all of them. From my experience, I would say probably 50-50 will, so 50% will just opt for expected management and carry on as triplet, and 50% will opt for selective reduction. That's just my experience.
So there's one question on a monochorionic twin. If one twin dies, okay, does the gestational age at which it dies matter, or is there any other factors which you consider the overall prognosis?
Well, I think that's a very good question. I think gestation age does matter, because I think if it happens early in pregnancy, I think the risk is small. The risk that the co-twin is very small. I mean, if it happens in the first trimester, I think the majority of them, if the surviving twin is normal, if there's no abnormality, I think the prognosis of the surviving twin tend to be very good. I think the risk of neurological problem is very small, extremely small. To the extent that not everyone would do an MRI, the risk of preterm birth is small, compared to if the demise occurred late in pregnancy, so in the third trimester, for example. I think the risk is higher. So the risk of preterm birth is higher, as well as the risk of neurological problem is higher. The other thing which is interesting and not a lot of data, is whether actually single demise occurred after TTTS compared to if it's after the fact that you don't know the etiology. You can't find anything on the scan to tell you the cause of the demise. And I don't think we have a clear data on that. I suspect the risk will be higher if it's after missed TTTS.
And the one more question is, whenever there is a selective IUGR, do you do Doppler for both the twins, or is there a role for a Doppler on the normal size twin?
We do Dopplers on all of them. So the ISWA guideline, we said we do Dopplers for all of them, the bigger baby, the smaller baby. And I did share with you, obviously, the fact that not all the guidelines agree. So the Americans would not routinely recommend Dopplers if there's no size or fluid discordance, but we do Dopplers all of them. And if the selective fetal restriction, we Doppler both.
There is one question actually, Priya. The one Dr. Suresh has answered, but for the benefit of everyone, can you repeat it, Priya?
Yes, madam. The monochorionic twin, if the growth discordance is more than 35%, but the Dopplers are normal, and your patient is now at 34 weeks of gestation, when will you deliver? Like, will you wait or will you deliver just because the discordance is high? It's more than 35%, but the Dopplers are still normal.
Sir,
ma'am, I think she picked it up. She told that we will do a CTG then. So do you agree that you do a CTG in this kind of situations?
Are you asking me, or are you saying that Suresh has already answered?
No. I'm asking you.
Oh, yes.
For Suresh, there is another question actually.
Yes,
yes. And the other one.
Yes. No, I think if the umbilical artery Doppler is normal, completely normal, so even the PI is not raised, I would rely more on the MCA Doppler. So if the MCA Doppler, for example, is abnormal, I would bail out after 34 weeks. Certainly in monochorionic twins with that large size discordance, again, I would, push it maximum to 36 weeks, and I'll be monitoring carefully at the end of the pregnancy.
Okay, and there is one more question. After a cord occlusion, either by RFA, that is radio frequency, or by for TTS, how will you monitor and when will you deliver?
Sir, Suresh, Dr. Suresh has answered it, Priya. It out again. Dr. Suresh.
Hello?
Dr. Suresh.
Yes.
Sir, the question which you have already answered, but for the benefit of everyone, the after cord occlusion or RFA for TTTS, how do you
After cord occlusion RFA, we normally monitor 48 hours, we monitor them in the hospital, and then we ask them to do two weekly monitoring. Basically, we want to do immediately, we want to know the MCA Doppler and how the baby is doing for the next couple of days. And then if there is no other cause, for example, if that baby had a cardiomegaly, then I would follow her up after a week. If the other baby was normal, then we'll ask them to come after 2 weeks. And once after 2 weeks, then if it's fine, then 4 weeks later can be done. But if it's laser, then it has to be shorter interval.
Thank you, sir.
There is one question for you from the audience. A selective fetal reduction, is it allowed in the MTP Act? Till what gestation can we do? We said we'll give it to sir when he
Priya,
comes.
I think this needs
have
to be in a
discussed this,
different,
Priya.
yeah, I think just leave it at that because the MTP Amendment Act is going through and 24 weeks, although we are putting the gazette, it is still not into use. So it will take some time.
Okay.
So let's not.
Monitoring. There's also a question on monitoring monoamniotic twins complicated by FGR.
Yes, sir.
Well, if you have fingers, just cross them like that, and then keep watching them. Give tender, loving care to the mother, and says we will watch as much as we can, and when the time comes, we will deliver. So the thing is, monitoring monoamniotic twins, it is not different from monochorionic twins in any other way, except the fact that you cannot look at like a discordant. So you do the Dopplers, and if there's a cord entanglement, almost all monoamniotic twins will have cord entanglement, but we are not going to be worried about that. If there's a cord accident, it is going to happen, but there is very little we can do. We take the same rules as we do for Doppler otherwise, and then take them forward at the appropriate time of delivery. That's all.
Okay. Do you want to discuss those things from from the quiz session, or we'll leave it?
Yeah.
Okay. Can cardiomegaly be treated in utero medically? Now, it's important to remember that cardiomegaly in these cases is because of volume overload. Now, once I remove that offending agent, which causes the volume overload, then over a period of 1 to 2 weeks, this heart will come back to normal. There is no special treatment needed for that.
Okay. So I think all good things must come to an end, and we have had a wonderful session this afternoon, and I think all the sessions were very, very good, and I must thank all the faculty for doing such a wonderful job. The messages were really clear, starting from fundamentals to complicated management of twins, and on behalf of all of us at OGSSI, we thank our faculty. Asma, thank you so much. It's a pleasure to hear from people who publish evidence and talk and give us very strong messages. So thank you very much, Dr. Tony Tan, for his talk, and I really like the way he summed it up by saying that it is difficult to practice evidence-based medicine, but if you want to give women the best, then you must make the effort to keep abreast and do what is difficult sometimes. And Dr. Suresh, for sparing so much time and the wealth of your experience with us. And of course, Dr. Sudarshan and Shobhana, Vivek, for that lovely sessions on chorionicity and screening in twins, and all the panelists for being, for managing all the complicated cases. So thank you all very much. Thanks to the delegates. We had over 200 at the peak of the session, I think, and without them, this, they are the ones who make the meeting a success. To all the farmers who supported us, to Shield and the technical team, Chitrakala, for her support. To all the coordinators, Meenakshi, Akhila, Priya, for the enthusiasm and all the support, and the entire OGSSI team. All the chairpersons who were here right through and shared their experience and expertise. Thank you very much. And I now hand over back to Dr. Vijayalakshmi
Thank-
for her final words. Yeah, we can wrap
You
up.
have said it all, and you have said whatever I wanted to say. So that's great. Thank you. In fact, my only other comment would be to thank Uma herself, because she's been all through planning. And for the last, I think, nearly a month, every day I've been corresponding to her, communicating how to manage all the faculty to get in and then be in touch. So thank you very much, Asma. And special thanks to you, because although we shifted one session, but I'm really happy that you could still make it to come here and be
Thank you
in
very
person.
much for the invitation. It's a pleasure. It's a pleasure to be with
In
you.
person, so that's great. And of course, Dr. Suresh is somebody whom we look to for everything and anything in this, and we are really lucky and proud that he's around for us in Chennai. Thank you, Dr. Suresh sir, and of course Sudarshan, and as well as Shobna. Thank you so much, and all my OGSSI members.
Nice meeting you, Asma, after a long time.
Yes, Asma is muted. Asma, Dr.
No, I was just saying that it's a pleasure being with you, and I really enjoyed the discussion. I think it's great, and the questions are fantastic. Very clinical. So, great honor to be with you, and very supportive, and I think fantastic organization, and well done.
Thank you so much. Wait to see you more often then. We will be looking forward to. And thank you all, once and all. Thank you, Hepzibah, I'm happy that I shared the platform with you. Thank you. So I think tomorrow we have the full-fledged session starting from 9 a.m. inauguration. And then we have this time we have made it as discussion or even conversation with other faculty, other specialities. Asma, if you have time, you are most welcome to join us. I know you are all stuck with lots of things. So thank you very much, all of you, and see you tomorrow with another bright academic session, and then we move on. So thank you, my OGSSI team. So take some rest and come back with full vigor tomorrow again.
Thank you very much, and I really, from UK, just wanted to send you our best wishes and tell you that we are thinking of you, and I know that you and your families are going through a tough time, but we on behalf of my colleagues, we are really thinking of you and hope that things will get better soon.
Yeah, that is one thing that is one thing which is shadowing us everywhere. The only thing is we are trying to keep ourselves boosted up despite all those things, and try doing some knowledge sharing so that at least make use of this period with a lot of tension and stress. Thank you so much for your good wishes. Thank you.
Bye, everybody.
Bye. Okay.
Congratulations, Uma. Vijay, a very good show, excellent, good scientific learning.
Thank you, madam.
Thank you.
Thank you all. So thank you. Do we have a slide from Timen for projection? Priya? We said we will project the sponsor.
Yes, ma'am. Chitra, you are there?
Project that last one. Yeah. Yeah. Thank you, Timon, for supporting us, and just pass on our heartfelt thanks to your mates and your company mates. Thank you so much. So thank you, Shield, the entire team, and we will again be sharing the platform tomorrow. Thank you so much. Thank you, Priya. So we wind up the session. Thank you, Dhanalakshmi, for staying there.
Thank you.
Doing the panel well. Thank you. Thank you, sir. All of you, thank you. Thank you, Asma. Bye. We close the session.